Starting.
Okay. Yes, Sadhana ma'am.
Okay. Then you should get good to hear.
Pratibha Singh ma'am.
Have you registered now? Yeah.
Hello. Shall I start?
Yes,
ma'am. Yes, yes. Yes, ma'am.
Yes, Pratibha. Yes, sister.
So, good evening, everyone, and I warmly welcome all of you to this FOGSI ICOG certificate course on infections in pregnancy. And this infection during pregnancy can lead to serious complications for both mother and child, and making this topic extremely important in our day-to-day practice. Now, today it is 3-day certificate course,
Shreya, please
which is
mute.
designed to refresh your knowledge and update
Nilima,
you.
mute everybody, everyone except the speaker.
Yes, Shreya.
Hello.
Yes, ma'am.
So today on day 1, we will begin with the basics and cover non-obstetric infections, and our learned speakers will guide us through the fundamentals and discuss various bacterial, viral and other infections that can complicate pregnancy. Now this will be followed by a very interactive panel discussion on fever in pregnancy, and I encourage all of you to actively participate and make the most of this academic opportunity. I also want to remind you that there will be a post test at the end of this session, which is mandatory to obtain ICOG certification. So please ensure that you attend the full course. With this, I once again extend a warm welcome to all of you, and let us start by taking blessings from the God. So I'll request the support to start and play the prayer. So thank you so much, and you all know that this is the effort of our Dr. Sadhana Gupta madam, and I warmly invite Dr. Sadhana Gupta madam. She doesn't need any introduction. She is at present ICOG Vice Chairperson for 2026, and I request madam to say a few words and introduce our guest.
Can I interrupt in between Dr. Pratibha, Dr.
Yes.
Suvarna here?
Yes.
The thing is, I have a meeting at 4 o'clock. I
Okay.
got a message from Sadhana ji, and even Nilima told me. So I just joined. I just want to say good things about this entire program, that infectious diseases in pregnancy is really a topic of very high significance and importance to everyone. And I really appreciate the efforts done by the entire team. I will really have to log out because I don't have time. The other side, the other Zoom is already there, and I'm in the car. So it's just little bit difficult. But I think the certificate courses that have been going on, I've been seeing throughout the tenure. Dr. Sheila Male is doing a wonderful job. Dr. Sadhana Gupta is doing a great job. And of course, all of you who are the governing council members who have got a great opportunity to actively participate in all the activities of ICOG, and the certificate courses will go a long way in training our young members, young minds, and I'm sure this will really be very, very helpful. So thank you so much, and I'll have to really log out. Sorry for interrupting your flow of events.
Thank you so much.
Madam,
Thank
for
you.
joining us. Thank you. Thank you so much.
Thank you
Thank you
so
so
much
much.
for
Bye, 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 bye.
Thank you.
Bye,
Thanks
madam.
a lot.
Sadhana, madam.
So, warm welcome to this second ICOG certification course of this tenure. And Dr. Sheila Mane, our ICOG chairperson, our ICOG secretary, Dr. Pratik Tambe, and whole team of ICOG Governing Council. We are all geared up and we are taking all effort that our academics, right from basic to the updates and to the ground realities, we are planning the program so that it benefits every doctor and every person in our country and abroad also. So just I will brief a little bit about today's program. That today's session, today's program is focused on the non-obstetrical infection, and one basic, very crucial topic, that is what are the physiological changes which make the diagnosis of infection very difficult in pregnancy. And we have taken all those infections which are highly prevalent in our country and in our population. So this is something we have planned that it actually curtails to the need of our population. So UTI in entry cases, malaria, dengue, which cause a lot of mortality and criticality in our patient, tuberculosis, which is endemic, hepatitis, HIV, influenza, and COVID. And how, when a patient comes to us in pregnancy, how do we have the clinical approach? We are extremely thankful, all ICOG team, to all experts who have done commendable job, and all the speakers as well as the chairperson. So we look forward to a great discussion and a great learning program. And Dr. Bhaskar Pal, our president FOGSI, has sent all the best wishes to our program, and for some travel, he is not able to join. So I invite our ICOG chairperson, Dr. Sheila, very long time, to give her blessings and input to the program. Dr. Sheila Mane.
Hello. Good evening, everybody. And I welcome all of you on behalf of ICOG. And all of us know that this is our second certificate program. And I'm so happy to see that so many people have already logged in. That itself shows that this program is so powerful and so useful. And I congratulate Dr. Sadhana and her team for articulating such a wonderful program in 3 days. And I think everybody should utilize this opportunity to attend this and gain knowledge, because every day, so many things are changing. So basics, I think today's program is covering that. Yes, once again, I would like to thank Dr. Bhaskar Pal. He is not able to join today. And I thank Dr. Suvarna Khadilkar, who was busy, and she has already addressed this. So, and I think most of our governing council members are involved in this program. And Dr. Pratik Tambe is always there, guiding force and trying to give instructions and see that everything happens methodically. And today it is basics of infection, as already mentioned by Dr. Sadhana Gupta. And I can see many governing council members like Arup Kumar, Dr. Richa Singh, and Dr. Pratibha is already there, as well as I think most of them. Dr. Uma is going to be a faculty today, and Dr. Josna Suri, Dr. Mosmi Das, then Dr. J.B. Sharma, who has done so much of work on tuberculosis, like Dr. Satyamani, who is from Bangalore, Dr. Girija Wagh, Dr. Sanchita Dubey, Dr. Aradhana Singh, Dr. Vidya Thobi, Sukumar Barik. I think many are there. I may not be able to take everybody's name as everybody is waiting and we have to start the program. So once again, I wish the good luck. And those who have joined, I know sometimes some people feel that we are not able to join for 3 days, but I think once in a month, giving your 3 hours in the evening will be of a great help to all of us as well as to our patients, because we are going to cover most of the focus times, and we really have a very good feedback from our activities. I must share with all of you, wherever I go, people are giving and telling us, Madam, please, you can do this also. We would like to listen to this. We would like to know about it. So that is the impact of ICOG, and really feel very happy to know that people are eager to join and test. So very nice to see that already around 298 people have already joined, and I know within 10 minutes, I think we will be definitely having more and more people joining. So once again, thank you, and I wish good luck to all of you. And I think I request Dr. Pratik Tambe also to just say a few words before we start the program.
Thank you very much, Dr. Sheila Mane ma'am, for being a guiding force and taking ICOG to new heights. We have broken all barriers and crossed all records which we have set previously. ICOG certificate courses are something which everybody looks forward to. We have more than 1,300 registrations for this particular course on infections in pregnancy. It just shows that academics, as propounded by ICOG, is of the highest order. I wish everybody all the very best. Thank you very much, Dr. Sadhna Gupta, and the entire team of conveners and coordinators for all 3 days for doing such a mammoth task. I wish you all the very best, and please carry on with the academics.
Thank you, Pratik. And you are like something anchor around us to whom we always look forward. Today's our coordinator is today program Dr. Maushmi Das Ghosh from Jamshedpur is our coordinator, and thank you, Maushmi, for all the hard work which you are doing. And I request you to start the program. And Nilima, I think we will have some few minutes for this pre-test questionnaire. Nilima?
There are no more pre-tests, ma'am. It's only a post-test.
Only post-test is there.
Only post-test, and that is usually around 6:45, 7 p.m.
So fine. So, Maushmi, you please go ahead with the scientific.
Thank you, madam. So, good afternoon, ladies and gentlemen. Today is the first day of the program of ICOG certification. The first session of the day is Basics of Infection in Pregnancy. We have two chairpersons, Dr. Arup Kumar Majhi and Dr. Richa Singh. So to introduce Professor Arup Kumar Majhi, he is the governing council member, and presently he is the professor of Shantiniketan Medical College, Bolpur. We have with us Dr. Richa Singh. She is the professor and former HOD of SN Medical College, Agra, and now president of Agra Obs and Gynae Society. We welcome you, Majhi sir and madam, and request you now to chair the session on a very useful and very important topic. And I request you to kindly introduce the speaker and start the session.
Thank you, Dr. Mosumi, for your kind introduction. Really very glad to see all the stalwarts today, Dr. Sheila Madam, Dr. Sadhna, Dr. Pratik, and all of you, the Dr. Pratibha, Achla, and Shoshiwala, and Mosumi, for your constant hammering for this program. And it is really, I am very glad to see that so many programs are being arranged and all are very popular. Today is also the 7 p.m. there is a program. So nothing more I will say. And now the next speaker is actually Dr. Aruna Nigam. All of you know, she is very known for her academician and her contribution in the academic, and is the ex-head of the department, Amrad Institute of the Medical Science and Research, President Indian Society of Colposcopy and Cervical Pathology, is the ICOG member this term, and have more than 250 publications, citations, more than 4,000, and editor of the two important journals and many awards to her credit, including Women Scientist Award 2020 for special contribution, and started educational website in 2020 for undergraduate, postgraduates, and OBG call center with latest updates and video later. So Dr. Aruna will speak on any very important subject, the basics of the infection, because always the body tries to adapt there is to overcome of the problems. One of the infection is the important cause of mortality and so many morbidities. So maternal physiology and immunological adaptation relevant to infection, and will be presented by Dr. Aruna Nigam. Now, Dr. Aruna, it is your chair and platform to start your topics.
Thank you, Dr. Arif, for such a nice introduction, and thank you, Dr. Sheila Mane, Dr. Sadhna Gupta, for giving me this opportunity to talk on this very important topic. You see, we have been taught physiology, anatomy in the first year, and how often we have revised it, how often we have correlated it. That is very important. You will love the subject if you correlate your anatomy, physiology, and all adaptation with your clinical practice. And then you don't need to remember everything again and again. So with this, let me start with the topic, and I'll try to finish in next 15 minutes, so be with me. Okay, so what I'm going to talk on, first be taking on the immunological adaptations, then on a physiological adaptations. In immunological adaptations, I'm going to talk on the immune balance, trimester-wise overview, and overview of the changes in innate and adaptive immunity and its correlation. In the physiological adaptations, I'm going to take on only four parts which are related with the infection, that is a respiratory system, microbiome, gastrointestinal changes, and urinary tract changes. So you see, what happens in the maternal immunological adaptation? This is a fetus. And what is it? It is a semi-allogenic graft. And what now mother has to do? It has to change somewhat. So maternal immune system must achieve complete immune tolerance to fetus while preserving robust protection against environmental pathogens. So there is an old myth that there is a global immunosuppression. No, we have to change the concept, and in reality, there is a qualitative immune modulation. There is a highly orchestrated immune response, which is compartment specific, which I'm going to take on, and defense is not lost. It is reprogrammed. So let's talk on immune balance, trimester-specific immune shift between the pro-inflammatory and the anti-inflammatory factors. If you see the trimester-wide wave, it is a dynamic U-shaped inflammatory curve, as you can see here. So here you can see that there is a pro-inflammation and this is a anti-inflammation. The first trimester, there is a pro-inflammatory peak, which is crucial for successful implantation, vascular remodeling, and initial placental development. And how this happens, there is increase in the pro-inflammatory cytokines like IL-1 beta, IL-6, and TNF-alpha, increased chemokines, increased C-reactive protein, increased leukocyte activation. In the second trimester, there is a anti-inflammatory trough, and which is required for the period of rapid fetal growth, requiring profound immunological tolerance and suppression of the rejection. And in this phase, there is a decrease in the pro-inflammatory cytokines, increase in the anti-inflammatory cytokines, IL-4, IL-10, and TGF-beta. There is a stabilization or slight decrease in CRP, and there is an expansion of the Tregs. I'm going to talk on detail regarding Tregs and the Bregs. In the third trimester, again, there is a pro-inflammatory peak, and why it is required? It is necessary that this immunological shift is required to trigger and support cervical ripening, labor, and parturition. So there is an increase again in the pro-inflammatory cytokines, IL-1 beta, IL-6, TNF-alpha, increased C-reactive protein, acute phase reactants, increased prostaglandin synthesis to have a good parturition and cervical ripening, and increase in the leukocyte infiltration. So in this way, this U-shaped inflammatory curve works throughout the pregnancy. Let's talk on the two immunity which are very important for the body. We all know that there is an innate immunity and there is a adaptive immunity. Innate immunity, that means immediately what is required. So this is being done by complement system, neutrophils, monocyte, and NK cells. In adaptive immunity, we will talk of T cell, B cell, and immunoglobulins. Let's talk of innate immunity first. So taking one by one, the complement system. There is an increase in the C3A and C5A, and if any dysregulation is occurring during this time in this system, it leads to preeclampsia and preterm birth. What happens to the neutrophils? There is an increase in the count, increase in the baseline activity, but simultaneously there is a decrease in the response to stimuli. That means, although this is activated at the baseline, but functionally regulated. Then, if we talk of a monocyte, there is an increase in total monocyte and there is a shift towards intermediate monocyte. That means a tolerant phenotype is activated. Regarding the NK cells, there is a decrease in the numbers, which is important for immune regulation rather than cytotoxicity. Now, once understanding the innate immunity, it is very important to understand the adaptive immunity. So in adaptive immunity, as we talk, we have to talk on the T cell, B cell, and immunoglobulin. So if you see in the T cell, there is decrease in the total number of T cells, and the very important component is that there is a shift from T helper 1 to T helper 2. So what it does? It causes improvement in the Th1 mediated disease like rheumatoid arthritis, autoimmune diseases, but there is a worsening of the Th2 mediated disease like skin diseases and allergic disorder. What is happening with the B cells? There is a decrease in the B cell count, and there is a physiological B cell lymphopenia, and there is a decreased antigen responses. I told you that I'm going to talk something about the Treg and Breg. This is not T-Rex of your Jurassic Park. It says Treg, T regulatory cells, and B regulatory cells. So there is an increase in this Treg and Breg, and which is responsible for the protecting the fetal interface. But simultaneously, with this increase, there is an increased infection risk. There is an increased susceptibility and severity of the influenza. That's why vaccination is advised. Malaria, hepatitis E, varicella, and severe fetal outcomes like torch infections, Zika, and CMV. What happens with the immunoglobulins? It remains stable or decrease, especially in later part, but there is a relative increase in the Ig1, which is important for the placental transfer in the third trimester. That is why we target our vaccination like Tdap in a third trimester. There is a structural change, there is an increased glycosylation, which leads to good anti-inflammatory effect. Now, the special antibodies, which I have already talked, that there is an increase in the IgG1 type, which is responsible for the fetal protection. Once we have related this with immunological adaptation with the infections, let's talk of hurriedly in these four systems, the respiratory changes, microbiome, urinary tract, and gastrointestinal tract. I have not taken any other system to talk on because these are the systems which we are worried most. So if we talk of a respiratory adaptation changes, there can be anatomical changes and there can be a functional changes. If we talk of anatomical changes, there is a progressive enlargement and softening of the uterus, which is causing the elevation of the diaphragm. The hormonal influences causing an increased subcostal angle and outward expansion of the ribs, and there is a decreased chest wall compliance by 35 to 40%. In a functional respiratory changes, there is a decrease in the functional residual capacity. There is a resting minute ventilation increase, which contributes to pregnancy and associated breathlessness. And that is the reason of a development of a physiological dyspnea, which is very common in pregnancy. Now, as there is a minute ventilation is increased and there is a decreased functional residual capacity, this leads to compensatory respiratory alkalosis. And this is very important to identify if you are involved with the critical care or HDU maintenance. Now, there is a shift in the oxygen dissociation curve, which facilitates the placental oxygen transfer and enhances the fetal oxygen availability. And the clinical application of this is that the physiological dyspnea may mask the underlying pulmonary pathology, reduce respiratory reserve, leading to limited capacity to tolerate hypoxia and an increased risk of rapid decompensation in a pulmonary diseases. If we talk of a microbiome, a very important, and nowadays everywhere we talk of a microbiome. As such, as a gynecologist, you are related with the vaginal microbiome, but you must consider the gut and the oral microbiome when we are considering the pregnancy-related changes. So vaginal microbiome, as we all know, is dominated by a lactobacillus, and a beautiful classification has been given in 2011, and where it has been divided into community state types. So routinely there is a dominant of a community state 1 and 5, but here what happens in presence of this biosis, there occurs a dominance of the CST4, which increases the chances of bacterial vaginosis, chlamydia, candida, leading to fetal infections and adverse pregnancy outcomes. If we talk of a gut and a oral microbiome changes, there is decreased alpha diversity and increased actinobacteria and proteobacteria. I'll come to it later on how it can be related with the gut changes and susceptibility. If we talk of a pregnancy-specific urinary adaptations, see, the progesterone causes smooth muscle relaxation, everybody knows. So there is a decreased urethric peristalsis leading to urinary stasis. Mechanical factors like enlarging uterus compresses the ureter right more than left. So there is a physiological hydroureter and hydronephrosis. There is a decreased tone of the bladder and increased capacity leading to incomplete emptying. And all these are causing the stasis of the urine leading to the increased chances of infection. Moreover, there is a change in the component of the urine. There is an increased renal plasma flow and GFR leading to glycosuria and amino acid urea. So the clinical relevance of this is there is a palectasis, reflux leading to increased risk of ascending infection. That is why asymptomatic bacteria needs to be treated. Glycosuria and altered urine composition leads to bacterial overgrowth. Common pathogens are increased. Clinical implication is there is a asymptomatic bacteria leading to pyelonephritis, preterm labor, and low birth weight, and that mandates a routine screening and treatment of urinary tract infections and asymptomatic bacteriuria. And this is the last slide of mine where we are going to correlate the gastrointestinal changes. So there is a decreased motility leading to prolonged intestinal transit time. There is a decreased gastric emptying, decreased lower esophageal sphincter tone. So there is a reflux tendency, decreased gallbladder motility leading to bile stasis, and the microbiome alterations, which I just have discussed. Overall, there is an immune modulation, Th2 dominant state is there, and this prolonged blood transit lead to increased risk of bacterial overgrowth. Altered microbiome lead to increased GI infections and systemic inflammation. There is a reduced cell-mediated immunity leading to listeriosis and salmonellosis, we all know, and the biliary stasis leads to increased risk of gallbladder infections. So I hope you are able to understand how the physiological and immunological adaptation can be correlated with the infections. Therefore, I can conclude by saying that maternal immunity is dynamic, trimester specific, and highly regulated. Pregnancy is a state of controlled immune tolerance with a preserved defenses. Hormonal changes affects the motility of all organs, leading to stasis that causes bacterial overgrowth. And understanding of these helps in deciding vaccination strategies in third trimester, infection management, and autoimmune disease care. So thank you all for your patient hearing. And this is my latest book on recent advances in Obs and Gynae, 4th edition, released just now. So all of you can go to Amazon and there is a very important topic, tropical infections, taken in this book. Thank you all for your patient hearing.
Very well spoken, Dr. Aruna, about the immunological changes and how the pregnancy, because of the immunomodulation, is more susceptible to particular infections, especially. I would like to make a mark that the immunological responses which occur naturally are something which helps in the prolongation of pregnancy and preventing pregnancy loss, especially the Th1, Th2 immune responses, the prostaglandin changes, and later on a successful parturition at term. So very well explained. And you also made it a point to which infections pregnant lady is more susceptible, and so we should keep in mind during her antenatal care to be vigilant for those infections. And if screening is required, we should do that, like UTI prevention is required, influenza, and especially hepatitis E, which becomes very rampant in pregnancy. So we should encourage them to maintain hygiene in the whatever food they are taking, so that they are not exposed to hepatitis or least exposed to hepatitis E infection, because that becomes permanent and at times is responsible for maternal mortality also. So, very well explained, Dr.
Thank you, Dr. Aruna Nigam, for such an excellent presentation. I thank both the chairpersons, Dr. Arup Majhi sir and Dr. Richa Singh, for giving their valuable time. I request you all to please stay on with us for the entire program. Moving to the second session, it is on UTI in pregnancy. I welcome the chairpersons, Dr. Kiran Chandana, Dr. Aruna Suman, Dr. Shashi Bala Bhosle. To introduce Dr. Kiran Chandana Madam, she is the director of Chandana Medical Center, Faridabad, and presently she is the president of Faridabad Obs and Gynae Society and vice president of Faridabad Menopause Society. It is my privilege to introduce Dr. Aruna Suman. She is the professor in Government Medical College, Jagtial, Telangana. She is also the chairperson of International Exchange Academic Exchange Committee 2026 to 28. She was the organizing secretary of AICOG Hyderabad 2024. Dr. Shashi Bala Bhosle Madam. She is the governing council member and the founder president of Gwalior Menopause Society and chapter convener Association of Menopause India and coordinator of IA.
Mausami, you have muted.
Mausami, you are muted.
Please unmute yourself, Mausami. Yeah.
Okay, sorry. Was I muted through the entire session?
No, it's fine. You can hand over to the chairpersons now, please.
Yeah. Sorry
And for the audience, I'd just like to mention that if you have any questions for any of the speakers, please put them in the chat box. We'll try and see to it that they're addressed in the chat box by the speakers themselves.
So the chairperson, all yours now. We have two speakers.
Yeah,
Dr. Shruti Bhavi and Dr. Uma Pandey.
Yeah, can I introduce Dr. Shruti Bhavi Patil?
Please go ahead.
Yeah, yes. Dr. Shruti Bhavi Patil is going to talk about UTI in pregnancy, and she is MU coordinator from this, and she's president.
Shashi, you can make a brief CV. We are
Okay, ma'am. Okay,
yes,
associate professor and unit chief. She's from Karnataka, Gadag. Over to you, Shruti.
Thank you so much, ma'am. Can I share my slide?
Yeah, sure.
You'll need to share the PowerPoint window, ma'am. You're sharing your browser.
Yeah.
You'll need to stop sharing and reshare it also.
Yes. Okay. Is it visible?
No, it's not. That's why you need to stop sharing and share again, please.
Okay. Top share.
Yeah, you can go full screen now. Awesome. Please proceed.
Yeah. Thank you so much for the entire ICOG team and Dr. Sheila Mane madam for giving me this wonderful opportunity. I also congratulate the entire team for the wonderful webinar series going on for the ICOG certification. So my topic for today is urinary tract infection in pregnancy. So these are the most common bacterial infections, and they constitute among 8% of the infections during pregnancy. And already Aruna madam has beautifully explained the anatomical and mechanical factors which are leading to vesicoureteral reflux, and thus leading to the stasis, which will cause the lower and upper urinary tract infections. So the these are classified based on the site of infection. The lower urinary tract comprises of the asymptomatic bacteriuria, which is the most common and notorious thing during pregnancy, and along with the cystitis. And pyelonephritis is the upper urinary tract infection. So the asymptomatic bacteriuria is not symptomatic, but it is the most common encountered infection. So we need to screen universally all pregnant women to detect this asymptomatic bacteriuria. And the symptoms, infections include the cystitis, or it may, if it involves the bladder, and if it involves the calyces, renal, pelvis, and parenchyma, it is the pyelonephritis. And most organisms are from the perennial flora, which affect the urinary tract, and E. coli being the most notorious one, which is affecting 90% of the UTIs. So coming to asymptomatic bacteriuria, it is defined as presence of actively multiplying bacteria with a significant bacterial count in patients who are asymptomatic, and they contribute to 2 to 10% of the pregnancy. So like I told, screening is very important, and it has to be done in the first prenatal visit, because we need to detect and treat this at the very first visit. If untreated, it can also lead to further ascending infections, pyelonephritis in 25% of the cases, and thus leading to other pregnancy complications like preterm labor, sepsis, anemia, even ARDS. So to avoid this, we have to screen this. And midstream urine culture is the gold standard to detect asymptomatic bacteriuria, and it has to be an clean catch midstream urine. So the positive urine culture prompts immediate treatment, and if it is more than 10 raised to 5 organisms per ml, then it is diagnostic of asymptomatic bacteria. And according to ACOG, if there is negative culture report in the initial screening, then repeat culture is not recommended anytime during the pregnancy. So, like I told, the significance of screening is because if we do not treat, once we detect, 25% of them will develop a symptomatic infection during pregnancy, and that is why we need to screen and eradicate these bacteriuria. So the treatment is, it has to be a 5 to 7 day long course with a complete regime of antibiotics. And if at all we encounter a low colony counts on the urine report, it should be noted as the infection which needs a group B streptococcal prophylaxis during the time of delivery. And in the culture, if we get a normal vaginal flora like the lactobacilli or the cornybacterium species, these cases need not be treated. So the antibiotic regimes which are used in the lower urinary tract infection, that is symptomatic bacteriuria and cystitis, the first line being the nitrofurantoin. It is 100 mg orally every 12th hourly for 5 to 7 days, followed by cephalosporins and amoxicillin and amoxiclavulinic acid. So though these are having high degrees of resistance nowadays, and if we are giving an empirical treatment without knowing the exact culture sensitivity report, so it is better to avoid these two antibiotics. So coming to cystitis, it is again, it is symptomatic and characterized by dysuria, urgency, frequency. And on the urine analysis report, it could be pyuria, that more than 5 white blood cells, that is WBCs, in the urine, or it can be also the presence of components like leukocyte esterase, nitrites. All these suggest sensitive urine report. So even there could be a microscopic hematuria, RBCs could be found. So again, to confirm the diagnosis, the report will say 10 raised to 5 colony forming units per ml. So even if this is untreated, it could lead to pyelonephritis, which is again a complicate pregnancies. So like I told, the urine analysis report will be having these components, and the sensitivity is mostly in 70 to 90% if it is nitrites or leukocyte esterase positive, or if it is a 3+ proteinuria. So again, the treatment is 5 to 7 day course of antibiotics, which include the beta-lactams, nitrofurantoin, sulfonamides, and avoid amoxicillin, ampicillin regimens if at all we are giving a empirical therapy. So it is 90% effective if it is, most of the regimes are 90% effective if we are giving a complete 7 days regime. So it also can be mucopurulent cervicitis or urethritis in the lower urinary tract infections with pyuria. The organism could be Chlamydia trachomatis, and in these cases, azithromycin therapy is also quite effective. Coming to the upper urinary tract infection, that is acute pyuritis, it is one of the most common serious complication of pregnancy affected in the urinary tract infections. So young, mostly it affects in the second trimester, and usually the symptoms are right-sided, unilateral, and there is abrupt onset of fever, high degree fever, 38 degrees Celsius or more, with shaking, chills, and tenderness at the costovertebral angle, or that is pain in the both lumbar areas, along with, in case if the patient is very toxic, she may have nausea, vomiting, and even severe dehydration. So again, the urinary report will show leukocytes, clumpy bacteriuria in 15 to 20% of cases. And E. coli is again the most common organism responsible. And Klebsiella, Proteus, Enterobacter, again, these are in 3 to 5% cases. These organisms also can be found. Creatinine can be monitored to monitor the reports in this complicated pregnancy. So the differential diagnosis, because she is having symptoms of pain and all, we can even, she may be in labor or chorioamnionitis, appendicitis. It could be even a case of placental abruption, infarcted leiomyoma. So these are the differential diagnosis when a patient comes with pain symptoms. So because of the uterine activity from the endotoxin, she could have a early labor or preterm labor, and there could be, because of the alveolar injury manifested by the endotoxins, she can have frank pulmonary edema, one of the serious complications of pyelonephritis. And again, the injuries can cause hemolysis with microscopic hematuria, and leading and also in severe forms there could be renal dysfunction. So this is the only urinary tract infection which needs admission to the hospital. It has to be an inpatient management, and IV hydration and antibiotics simultaneously we need to restore. And the first line management are broad spectrum beta lactams along with aminoglycosides and ampicillin and cephalosporins. So if there is high fever, we need to cool the hyperthermia along with using acetaminophen and other antipyretic agents. So the treatment is IV regimes with ampicillin and gentamicin, 2 gram IV every 6 hourly, or the cephalosporins. So in case of beta-lactam allergy, astringent 1 gram IV 8 to 12 hourly are the regimes which are followed. So the systemic management, which includes the blood cultures, hemogram, complete hemogram, and of course vital monitoring, chest radiograph to in case if we are suspecting pulmonary edema. So the blood cultures need to be blood tests need to be repeated every 48 hours to monitor the renal function, and then once she is febrile for 24 hours, then we can consider oral antibiotics, and after the treatment we can repeat the culture up to 2 weeks after the complete treatment. So if there is persistent spiking fever or lack of improvement even after 48 to 72 hours, we must suspect any obstruction or any other complication. We have to again screen by using ultrasound or abdominal X-ray and then MRI imaging, which can also detect these any bladder stones or any other obstruction, kidney stones. So the treatment would be cystoscopic placement of DJ stenting or surgical removal of the stones. So the percutaneous nephrostomy the treatment. So again, for recurrent UTI, I think Uma madam next, she will be telling elaborately on this. So this will be nitrofurantoin continuously throughout the pregnancy at bedtime. So my take-home messages would be, there are significant physiological and anatomical changes which are having high prevalence of UTI or pyelonephritis, and the gold standard would be quantitative culture methods.
I think she has a network
She
issue.
lost the connection.
Yes. She's, I think, almost
I think
finished.
it is over.
Yeah, I think this is the last
Almost
slide.
finished.
So we can request Dr. Aruna to introduce the next speaker and
Yes, ma'am.
comment if any. Yes.
Yes, ma'am.
Yes.
Thank you for the opportunity, Sheila Mane ma'am, Sadhana Gupta ma'am,
Welcome.
Pratik Tambesa. Thank you so much.
Welcome.
And it's my pleasure and privilege to be here. And Dr. Shruti, yes, it's a very good talk. You have covered almost everything, and you have explained how important it is to do the screening for asymptomatic bacteriuria, and how this should be identified and treated properly so that it won't go into the severe issues like pyelonephritis, where the woman can go into sepsis, and as well as she can have preterm labor with growth restriction. Thank you so much. It's my pleasure to introduce the next speaker. Can I have her slide, please?
I think I have done the slide
Uma
show.
Pandey.
Dr. Uma Pandey, dear friend of mine.
Thank you.
I think you were
Can I have
sharing
her
the
slide, please?
You were sharing her presentation. You can start with
Should
your
I
first slide.
should I
Please
get
go
back?
ahead.
Uma, your presentation has your CV. She can talk about it.
Yes,
Uma,
exactly. Yes, exactly.
She shared the
Then
wrong
we
please,
project
slide.
that.
please
Okay.
project it, Dr.
Sure.
Uma.
Yes, ma'am. Yes, ma'am. I'm too excited to do that. So this is my PPT, which is going to be go on slide.
Can you focus on the slide with your photograph and CV, please?
Yeah. So this is my photograph. A very
Yes,
nice
yes.
photograph. COVID
Yes,
time.
Uma. Yes.
बहुत
She's a
पुराना है.
professor at Institute of Medical Sciences, Banaras Hindu University, former HOD at the same place, examiner of MRCOG, and she participated in Champion Trial, was principal investigator, and published in New England Journal. I welcome you, Dr. Uma. Please continue with your talk.
Thank you so much, ma'am, for your kind introduction. So, Madam Shruti has already covered a couple of things, so that makes my life easy. So, urinary tract infection results from microbial invasion of urinary tract, which is usually sterile. We do know that. Unlike vagina and unlike anal canal, which is not sterile. Lower tract infections result from invasion of the urethra and bladder, and respectively termed urethritis and cystitis. That's easy. The upper tract infection involve the ureters and kidneys and called ureteritis and pyelonephritis. We have just discussed pyelonephritis. Both lower tract infections and upper tract infections can be considered uncomplicated or complicated. So it can happen either way. So what's happening? Yeah. So now comes the complicated UTI. So what is complicated UTI? Something which is complicated, as simple as that. Considered when there are associated with any underlying condition that increases the risk of treatment failure. So that is complicated. That could be a woman who is pregnant. Aruna ma'am was just explaining that woman is pregnant. She will develop infection. Chances of infection much greater than any other woman. Diabetes, we know that. HIV, we do. Immunosuppression, infection with multi-drug resistant pathogens, functional or anatomic abnormalities of the urinary tract, renal insufficiency, and renal transplant. This is the kind of a slide showing that complicated urinary tract infection, obstruction, calculi or stenosis, that will lead to infection, presence of instrumentation, indwelling urinary catheter, stent or nephrostomy. If it is there, then I'm sure you know more than me, but I just talk like this. So its indwelling urinary catheter stent will result in infection. So what medicine? Madam has already discussed, Shruti madam, nitrofurantoin, most active against E. coli. So you have to remember this. If creatinine clearance is less than 30, be very careful. Okay, it's a very favored antibiotic in our setup I have seen. Avoid if systemic signs of infection or suspicion of pyelonephritis or prostatitis, that is for obviously males, does not cover protease. Then comes the trimethoprim and sulfamethoxazole. Do not use if resistance more than 20%. Monitor potassium level. This is important. Monitor potassium level if concomitant use of spironolactone, angiotensin converting enzyme inhibitor, ASI, ARBs. Okay, we have to be, we do not know, we talk to our nephrologist and then go ahead with the treatment. Second line could be cephaloxin. Cephaloxin is readily available and safe antibiotic. E. coli, Proteus, Klebsiella. Then comes the fosfomycin, which is a new antibiotic, active against E. coli enterococcus. It is also active against ESBL positive E. coli, and its susceptibility testing is recommended. And it is just one dosage. You just dissolve it, and during the night time you drink it and you go to bed, and try not to pass urine throughout the night time, and then only it will work well actually. So factors suggesting of the complicated, this is related to both sex, advanced age, presence of an urban department, emergency department, hospital acquired, again pregnancy has come, then childhood UTI that will lead to further urinary tract infection, symptoms for more than 7 days, diabetes is always there, and genitourinary abnormalities. A wide variety of GU abnormality may be associated with complicated urinary infection. Most common determinants of infection is interference with normal voiding, leading to impaired flushing of bacteria. This interference of voiding, all women in our department, or my sister used to work in court of law. Now she's judge, but she would say, I don't drink water during the daytime because there is no clean toilet. Sometimes it happens when we are going for camp or something. So this has been tackled by this government a lot, but we need to do more on that topic. The mechanism of infection include obstruction for incomplete urinary drainage, persistent bacteria in biofilm on stones. Then comes the indwelling devices, introduction of organism GU tract through instrumentation. Okay, so that is why when our residents, they catheterize a woman, they should be told that if woman size of the urethra is only 4 centimeters, and please, when you're catheterizing it, keep it really clean, because your single act of catheterization to a woman can really harm her. A chronic indwelling catheter is uniformly associated with bacteriuria, while infection complicating a single obstetric ureteric stone may be transient, especially with stone removal. So here comes the structural and functional. I think we have both of us, Dr. Shruti and myself, have discussed. So complicated urinary infection occurs in both women and men, because uncomplicated is rare in male, because we always teach it is 18 centimeter of length in men, and it is 4 centimeter. So God has been really unkind to women. So recurrent urinary infection in postmenopausal women is associated with genetic or the behavioral risk factors. Those in younger women with acute uncomplicated urinary infection, including a greater likelihood of being a non-secretor and history of poor infection. Here comes the postmenopausal women with recurrent urinary. We all know in our families, in our mama, in our masi, that those who are postmenopausal, they do suffer, and a lot. So somehow we have to deal with them. If they have cystocele, if they have prior genitourinary surgery, then that is going to be troublesome for that. As a population, postmenopausal women with recurrent urinary tract infection encompass elements consistent with both uncomplicated and complicated. Here is the clinical presentation. We have discussed that asymptomatic urinary infection or asymptomatic bacteriuria is the most common. Prevalence of bacteria is very high, reaching 100% in chronic indwelling catheter to 40% in neurogenic, because neurogenic bladder is not emptying well, that's why. Clinical presentation of symptomatic infection in patients with complicated urine varies across wide spectrum. Complete urinary obstruction or trauma to bacterial genitourinary tract, especially with hematuria, appears to be associated with more severe. So the hematuria component will leading to infection will happen if the blood is lying there, not if she has passed blood or he has passed blood. So infective organism, a wide variety of organisms are isolated from complicated E. coli, but it is isolated more frequently in women than men. E. coli strains isolated from symptomatic patients with complicated urine infection. Many other gram-negative organisms are isolated from complicated urinary infection. That is gram-negative as well. All of them were urease positive, that is Proteus mirabilis, Providentia, Morganella. And then we have Pseudomonas, which is one of the notorious infections. Enterococci and coagulase are the common gram-positive we have. And this is asymptomatic. Candida, if many people have Candida in the vaginal infection and they develop Candida in the urinary tract many times, then you do urinary culture, you will find lots of Candida in that. Elderly patients and patients with chronic urological devices often have microbiological. So this we have discussed. I'm missing this. Recurrent UTI. Several conditions may predispose to increased risk of UTI in both men and women. That is like stasis, obstruction, reflux, all that. Vesicoureteral reflux that leads even when the fetuses will have problem. Cystocele and pelvic organ prolapse, functional like overactive bladder and urinary incontinence. Mostly it will be stasis of the blood. कहते हैं ना वो बहता जल पवित्र होता है, हम लोग को ये पढ़ाया जाता है, बहती गंगा जो है वो हमेशा पवित्र है. Recurrent urinary tract infection may be commonly seen in sexually active women without any identifiable structural, again because it is the size. Older men can often have urinary tract infection due to outflow tract infection. Recurrent is usually new infection. It is new infections with different bacterial organisms. So that's the way you would define that. You will get the culture report and that's the way we will decide that. If organism continue to be same, there is relapsing infection suggesting an inadequately treated source such as abscess, urinary stone, or prostatitis. The source of this recurrent infection is same. Typically rectal bacterial flora contaminating. There comes a slide in which describe how should you clean, how should you wipe yourself. Bacteria can easily ascend. They're very clever. It is important to differentiate rapid infection from a relapse. Rapid infection different, while relapse is the same one. So the relapse is defined further defined as a recurrence within two weeks of the of completing therapy. It is considered reinfection if it is more than 2 weeks, and the culture is the bacterium is different. Vast majority UTI typically seen in medical offices and clinics are reinfection and do not warrant extensive urological evaluation. Indications for imaging include persistent hematuria, kidney stone, all those infections which we have discussed. And recurrent UTI, there is a spermicide that will result in repeated infection. Spermicide and lack of estrogen doesn't go very well for the woman, right? So the any spermicide we have discussed, atrophic we have discussed, chronic diarrhea can result, cystocele, first UTI when young, genetic predisposition, and then there is postportal residual urine is there, so stasis is there, and multiple partners are there and all that. So personal hygiene, not many people know. We need to educate our student who come to BHU. Not washing hands when wiping vaginal area after voiding. Not washing hands after that. Okay. Taking bath instead of showers. So anyway, in India we take bath. We don't. We take showers. We don't take bath. So that is one plus point we have. wiping and washing the vaginal area from front to बैक टू फ्रंट, तो पीछे से नहीं करना बिकॉज पूरा एनल कैनाल का इन्फेक्शन आगे आ जाएगा. Not using clean soft wash clothes to clean the vaginal area, not cleaning bladder opening area. I mean, you have to be very careful anyway, that would be tender. Failing to use gentle liquid soap when washing, not using vaginal estrogen when appropriate in postmenopausal women. Here comes when the spermicide, I have already mentioned that. Recurrent UTI, we have kind of discussed. Frequency of urination. You should urinate. You don't want to stagnate your bladder with urine there. That is going to harm. I know it is difficult for women, but what can we do? Delayed voiding habits, hot tubs, that we don't, I mean, we not in Varanasi, we don't practice that. Frequency with pantyhose and all that. Bicycle riding, they are saying that it results in infection and volume taken of the fluid. Avoid long interval between the urination, said that at least 8 to 10 drinks, and shower instead of that. We have done that. Feminine hygiene spray, try not to do that. Vaginal diaphragm, that stretches the vagina and the urethra both, so that may not be very comfortable. Empty your bladder after sexual intercourse, as sexual relation can often trigger urinary tract. Very less number of patients, they do know that, not more than 10%. So I think that's a good idea. Then we have recurrent UTI, urinary tract infections. Maximizing personal hygiene, that we have discussed. Effectiveness of lifestyle, we have discussed. Methamine, that is something new. I think it is one of the pharma guides was sending me the message, Inca or somebody. So if the pH of the bladder is less than 5, then it works very well, they are saying. Converted to formaldehyde, I'm almost done. D-mannose is also recurrent UTI. Antibiotic we have discussed, and post-coital prophylaxis we have discussed. And so long term is a good slide. As a low dose estrogen, you can have antibiotic, you can have long term. Sometimes people give 6 months of antibiotic low dose, and then you can have effectiveness of prophylaxis. And that we have done. Back beta-lactam antibiotics, rapidly changing GI flora, carry a risk of Clostridium. This we know, we have discussed. And this is topical estrogen. We all are gynecologists. We all know this. This needs to be used.
I think
Especially
just to interrupt, Uma, I think you can give message only for the recurrent UTI in pregnancy in the last 1 or 2 slides, and not the whole age group. In pregnancy, recurrent
Yes, ma'am. I have this slide, preventing urinary tract infection.
Because your time is up, that's why.
Yes, I understand. I'm sorry. We know about the organism, we know the culture, we know when we need to investigate. These we need to teach is to patients, our patients. Wash hands before wiping. Wipe front to back. I've discussed toilet papers and all that. Reusable sponges. Use the gentle liquid soap. Wash clothes and clean the bladder opening with care. And then tampons for periods, we can use that. Avoid long intervals between urination. That will bacteria will lodge there. That's why. Don't wear tight clothing, and drink more water. Some extra vitamin C. Avoid irritating fluid like caffeine, and avoid activities which will increase risk of bladder infection. And estrogen vaginal cream we have discussed. Take antibiotics which is prescribed. And these are the UTI through medical history. Fever, urgency, dysuria. Sometimes there is a chronic long-standing fever that can result in that. So you can have suprapubic tenderness, we must examine, and nausea, vomiting, fever, chest. Low backache, urinary analysis. And these are the urinary analysis which is to be done, although very common, done with rarely hematuria, you can say, nitrite, you can see, and
requesting, sorry, Dr. Uma, sorry, Dr. Uma, your time is up, so please.
Okay, no problem.
And
no problem.
Focus your message on me.
Yes,
Can you
ma'am.
go to the last slide with the take-home messages, please?
Sorry.
Yeah, so you can say up to the management because your time is already up. Hi.
I have missed that slide. I'm sorry. Low term, I have already mentioned.
I think there's enough here for an entire oration.
The uropathogens response.
Uma, it was too good.
Dr. Kiran
We
Chandana.
we invite comment from the theatre.
Dr. Kiran Chandana will actually come.
Thank you, Dr. Uma Pandey ma'am, for your illustrative talk and recurrent UTI, how to prevent it and what are the treatment to be given. And the personal hygiene you told, it is very important. And second thing you told that we have to empty the bladder before and after the intercourse. And catheterization, while we doing the catheterization, it is very important to take the hygienic precautions so that the patient doesn't suffer. And if we give antibiotic, it should be given for proper time. And if after the antibiotics, the patient, we have to see whether it is a relapse case or it is a recurrent UTI. Then we have to treat that patient because otherwise it is going to have the recurrent UTI and patient can suffer. Sometimes we have to give the prolonged treatment for such patient so that there is no renal dysfunction in such patient. Thank you very much. Thank you.
Thank you, Madam. Kiran Chandana, Madam, and Dr. Aruna Suman and Dr. Shashi Bala Bhosle for chairing the session. And thank you to the speakers, Dr. Shruti Bhave and Dr. Uma Pandey. Moving to the third session.
You can hand over.
Moderating
You can hand
because,
over to Dr.
our,
Sadhana, madam. Yeah.
Yes.
Mosmi, you can hand
So
over.
because in this session, our co-convener as well as the coordinator is in faculty, so it's my honor to invite our esteemed chairperson, none other than Dr. S.N. Tripathi, who is Emeritus Professor, Department CB Medical College, Cuttack, teachers of teachers, and a deep, intensive Dr. S.N. who has been the founder for the ISOPARB organization. I warmly welcome Madam to, it's an honor to have you. Dr. S.P. Jaswar is our second
Network.
I think Dr. Sadhana Gupta is facing some network issues. Let's get on with the introduction of the first speaker, please. So Dr. Mosmi Das Ghosh is the coordinator for today, and she is a senior consultant and unit head at Tata Main Hospital in Jamshedpur. She is also president of the Jamshedpur Ujjivan Society, has a number of awards to her credit, and she's going to be speaking to us on malaria infections.
Thank you, Pradeep Zambe sir, Sadhana madam for a generous introduction. So can I start my topic?
Yes, please go ahead. We are already late.
Start, yeah.
Am I audible? Yes.
Audible and visible. Please go ahead.
Yeah. So it is malaria in pregnancy. It is a major public health problem. According to the 2023 WHO report, it is estimated that worldwide there are 249 million malaria cases, out of which 0.6 million malaria deaths worldwide. To the extent that Bill Gates said that malaria is a most important cause of poverty worldwide. if we want to get rid of poverty, we should get rid of malaria. And 12.7 million cases are exposed to malaria infection during pregnancy. So causative agents, Plasmodium falciparum is the main cause of severe morbidity and mortality associated. The others are Plasmodium malariae, ovale, and cholestae are less common causes. And Plasmodium vivax is increasing in incidence. This is the life cycle of malaria parasite. We all know it has 3 stages.
You lost the connection again?
I think she's facing some technical issues. Maybe a slide is not advancing.
Yeah. I think.
Yeah, connection issue. We'll just wait for her to rejoin because she just started.
Yes. Maushmi, are you there?
Yes, she's there. You can switch off your video in case there are bandwidth issues. You can keep the video off, continue sharing and speak. Then we can hear you.
Can we invite Dr. Jyotsna Suri, Pratik? I think because
I think if Jyotsna is
she's
there,
not able. Jyotsna, are you there?
Good afternoon. I am Dr. S.P. Jaiswal. I think Dr. Jyotsna is not here.
I can see her logged in. Maybe she's away from the desk.
Jyotsna here. Jyotsna is here. Jyotsna,
Now she is visible. She can share her.
Please. Jyotsna,
yes, I was not able to unmute myself. I think from the back end there was something. Yes, I'm very much there, madam. So should I share my screen then?
Please go ahead.
Yes.
Okay, thank you. Thank you so much.
So should I introduce her?
Yes, Dr.
Yes.
Please go ahead.
Dr. Jyotsna, she is a professor in Department of OPGY, Safdarjung Hospital in New Delhi. And she is a very renowned personality and very senior person also. She is going to speak on the dengue in pregnancy. Thank you, Dr. Sheila Mane. Thank you, Dr. Pratik, Dr. Sadhna. You have given opportunity to chair the session. Thank you so much. And Dr. Jyotsna, please start your talk.
Yes. So please, the time needs to be reset for me. Thank you so much. Thank you.
I think they have to stop the
thank
previous.
you.
Previous.
Share, restart the time.
Yeah.
Already.
Thank you, Sadhna madam and Dr. Sheila Mane madam, Dr. Pratik and all ICOG members for giving me this opportunity to speak here today. So it's a very important topic, that is the dengue in pregnancy. Now, dengue is caused by the arbovirus, and there are 4 serotypes of dengue virus, which are, a really serious threat. And unfortunately, India is an endemic area, as are many other countries in the world. So as the previous speaker was, Dr. Maushmi was talking about malaria, it's a very big public health problem in our country. And it is the vector, the mosquito, which is the culprit, the Aedes aegypti. More than 100 million infections are occurring every year, and they are leading to 22,000 deaths. Now, the important thing over here is that the case fatality rate from 20% can go to below 1% if we are detecting it in time and giving the adequate medical care. Another important epidemiological fact is that this infection is much more prevalent in the younger age group, that is the 15 to 49 years, and it is also seen more in females. So that means that our pregnant women are definitely at a higher risk of developing dengue infection. Now, coming to how do we diagnose dengue? So, there is a presumptive diagnosis, as we call it. Any person who has, traveled to or is living in an endemic area, along with fever and any two of the following, that is a nausea, vomiting, rash, aches and pains, especially the retroorbital pain, any warning signs, uh, positive tourniquet test and leukopenia. So warning signs, I'll be telling you what they are. So any two of these, if they have, even without the serological testing, it is said by WHO that you can make a presumptive diagnosis of dengue. So, what is the stages of dengue infection? Now, there is a febrile phase in which there is a high grade fever, which is of acute onset and it lasts normally between 2 to 7 days. Then there is a critical phase in which there is the plasma leakage because the dengue virus causes endothelial dysfunction leading to leakage. And this leads to the fluid collecting within the the ascites or the pleural effusion. It leads to organ impairment. It leads to bleeding disorder, mainly because of severe thrombocytopenia. And it may last for 24 to 48 hours. And this is the phase of, also the phase of defervescence and the most critical phase where the patient can progress to dengue hemorrhagic fever or the dengue shock syndrome. The third is the convalescent phase, which may last for days to weeks. So now if you see, this is the different phases based on the symptoms and the severity. So as I told you, here this is the high grade temperature and then the patient is improving, the temperature comes down and this is the critical phase where there may be shock as well as bleeding. So in the first stage there is dehydration. Second, the critical phase is the most important phase from the point of view of the clinician and for the risk of mortality for the patient. So shock, bleeding, organ impairment, and then the convalescence phase in which there is the symptoms of fluid overload. And along with that, you see the hematocrit is rising in this critical phase because of the fluid leakage of fluid and the viremia. Here, this is showing the viremia. It is maximum in the febrile phase. And if you see the diagnosis, so we have got the NS1. So in the beginning, when there is the high load of antigen, we are able to, isolate viral RNA or the NS1 test. So the beginning first 4 days, you will get the antigen test positive. NS1 is the test we normally do. And after that, it is the IgM. So if you are doing it in the critical phase, remember that NS1 may be negative and it will be the IgM which will be positive. Later in the disease, the IgG also will become positive. Now, I was telling you about the warning signs. So what are the important warning signs? Intense continuous abdominal pain or pain when palpating the abdomen. Persistent vomiting, it is defined by the CDC 2024. More than 3 episodes in 1 hour or more than 4 in 6 hours. Then fluid accumulation in the form of ascites, pleural effusion or pericardial effusion. Mucosal bleeding, altered mental status, drowsiness, any GCS less than 15, hepatomegaly more than 2 centimeter, and a progressive increase in the hematocrit in 2 consecutive measurements 6 hours apart. So by WHO, it is defined as an increase in hematocrit over baseline of more than 10% and a fall in the platelet count. So the management is very much dependent on the stage, at which we are seeing the patient, number one. Number two, whether the patient is having any warning sign or whether the patient is having shock. So we normally divide them into 3 groups. Group A, there is no warning sign, and these are the patients who can be managed on the OPD basis. But for obstetricians, we are in the group B because any pregnant woman falls in the category of group B. So all patients should be admitted. And along with this, in group B, you also have other patients like not tolerating oral fluids, coagulopathy, AKI, who are having breathlessness, and any coexisting medical disorder or a social risk on case-to-case basis. And for the group C, inpatient management again is recommended. These are the most critical patients who are already having shock and severe bleeding and severe organ impairment. Now, pulse pressure less than 20 millimeter of mercury. So what is pulse pressure? It is the systolic minus diastolic. Normally, it is around 40. So 120 minus 80, 40. Now, pulse pressure less than or equal to 20 is a very important sign of dengue shock syndrome, normally a phase of compensated shock. So this is one very important thing stressed by CDC as well as WHO and all bodies. If you see a narrow pulse pressure, think of it as shock, and she needs to be upgraded to the ICU. Cold extremities, capillary refill time of more than 2 seconds, again escalate to ICU. And if you are recognizing dengue shock syndrome early and managing it, you can save the patient. So you can see dengue hemorrhagic fever is less than 1%, but dengue shock syndrome mortality becomes more than 10%. So this is again showing you, that dengue with warning signs or without warning signs, both can turn into severe dengue, and what are the features. Now, quickly about dengue in pregnancy. So here, there is a higher risk of vertical transmission, which is well established if the patient has a dengue fever during the peri-delivery time. And the obstetric complications are the PPH, preterm labor, severe oligohydramnios, as well as a risk of IUD. Another disturbing thing is that the risk of dengue shock syndrome is much higher in pregnancy because of the physiological changes. So here the evidence also tells us all the risks which I have just told you. Now there is a risk, what are the other specific challenges in pregnancy with dengue, that we are having a challenge of assessing the patient. So the physiological changes make it difficult for us to appreciate the hemoconcentration, leukopenia, thrombocytopenia. Many times, we are confused whether it is physiological or it is a disease process. And another important thing, because of the enzymes are raised, liver enzymes, and platelets are down, we may think of HELP syndrome, severe preeclampsia, or AFLP and DIC as the differentials. The other challenge here in the management, how much fluid to give. We know pulmonary edema sets in earlier in a pregnant woman. So how much fluid, what to do, if it's a full term, should we contemplate terminating pregnancy? Is it dengue or is it septic shock? And if the patient goes into labor in the critical phase, what to do? So now coming to quickly about the management. In the pregnant woman without warning sign, we said we have to admit everyone, keep the temperature down during the febrile phase, give the paracetamol 6 hourly, tepid sponging, give plenty of oral fluids, but no NSAIDs are to be given. Maintain the input-output charting, do daily CBC, platelet, hematocrit, and organ function. Basically, monitor like a hawk for any danger signal, and keep monitoring till 6 hours after the end of the critical phase, and do the fetal monitoring according to the gestational age. When the patient is in the second part, which I told you, with warning signs. So if the patient is in that situation, she is already having warning signs and she's not able to take orally, you have to give IV crystalloids 10 ml per kg as boluses. You have to reevaluate, and as the patient improves, her hematocrit comes down, we can taper the fluid, and then, once she is accepting orally, we can put her in the first category bracket, like we told, that give plenty of oral fluids. But if she deteriorates, she will go straight into the category C. That is, you have to then give high doses of IV crystalloid solution at 20 ml per kg as small boluses. So you can give 2 to 3 boluses if she is not responding. her hematocrit is not coming up. So hematocrit we keep doing before the bolus, after the bolus. You see if it is increasing, is it stable, or is it, falling? So if it is stable or if it is falling, we are happy. If it is increasing, we need to give more boluses. And after 3 boluses of crystalloid, if patient is not responding, we can go to colloid if the patient is in the dengue shock syndrome. And 2 boluses of colloid are also, recommended here. In case she doesn't respond to that, then she needs to be started on vasopressors and looked into the other causes of shock. Maybe there is some additional septic shock, etc. So we have to keep doing this, monitoring the patient till the patient is afebrile for 48 hours without requiring antipyretics. She has a good urine output. She's, no evidence of bleeding. Her platelets are stable and her hematocrit is stable. Obstetric management, if the patient is in preterm labor and she is not in shock, we can consider giving her, nifedipine and playing with time by giving the corticosteroids till, the corticosteroid take action. You can give 48 hours of nifedipine or etosiban. Magnesium sulfate, again, if the patient is not in shock or critical, we can give them. We should not give aspirin to a patient who is having dengue. Any pregnant woman who's on aspirin, please stop it. And stop any prophylactic anticoagulation if the platelet is less than 50,000. Other things which we have to remember, avoid any obstetric procedure that can be postponed. So don't do anything which is not urgent. And in case the patient is in labor or there is she's come with bleeding or she has come with fetal distress and you have to do a urgent cesarean or delivery, maintain platelet over 50,000 for a vaginal birth and over 70,000 for a CS. Breastfeeding is allowed. Monitor the newborn to assess for vertical transmission. So this baby is a very high risk baby. The neonatologist has to be very alert to see that the baby has already got the infection. Role of blood and blood products. Here we are not waiting for 500 cc loss. The patient is already very sick. So even if she has a lesser amount of blood loss, you may have to take early decision to give blood. FFP is indicated if INR is more than 1.3. Platelets, if there is any case of severe bleeding or any active bleeding, or if without bleeding also less than 10,000, it is recommended to give the platelets. And prophylactic platelet transfusion has no place because it can lead to overload. So we don't give prophylactic platelets. That is not indicated at all. And vitamin K in case the liver enzymes are deranged and the PT is deranged. Platelets, it's important that if the patient is Rh negative, for every 30 platelet concentrates, you should give a 300 microgram of anti-D. And sometimes you may need to give group compatible platelet, and if you don't have the particular group. Don't give IM injection, don't give steroids routinely. I already said no prophylactic platelet transfusion, no hypotonic IV fluids. Don't overload patient with fluid, later we'll have problem. Withhold aspirin and NSAIDs. And this is a small series of our own cases. In October 2025, we had 5 cases in our critical care unit. All of them presented with thrombocytopenia. All of them had some kind of bleeding. And surprising thing is, none of them were giving history of, fever until we were probing with them. So fever was, very mild in them. I don't know if pregnancy suppresses the fever, but they were all dengue positive, all had low platelet. 2 of them had ascites, and that's how we had got their dengue done, because they were having severe thrombocytopenia. And unfortunately, one mother expired, one baby expired, but the others we were able to save. All had to be intubated. One needed a hysterectomy also. So,
Sorry to interrupt you, ma'am. Your time is up.
I know. I'm just going to read the take-home messages. So key learning points here are that dengue in pregnancy is a serious viral infection, and the physiological changes make it more difficult and challenging for the obstetrician. So important again, pregnancy is high risk and merits admission to hospital whenever a case of dengue comes to us. Delivery does not improve condition of the patient, so there is no indication to deliver unless the patient has come in labor or there is some other urgent obstetric need to deliver her. Differential diagnosis of DHF and DSS should be considered in all patients who are presenting with thrombocytopenia in the endemic area. Pulse pressure less than 20 should be taken as a sign of shock in all patients with dengue, and they should be admitted in the ICU. And avoid any surgical intervention. Do the tourniquet test in the febrile phase, because that's again very important to know which patient can deteriorate. And if your patient inevitably needs to be delivered, for vaginal delivery, meticulous suturing of episiotomy and cold compresses, and for cesarean, midline incision for cesarean, put a drain intra-abdominal and subfacial and establish the hemostasis before closure. So a senior obstetrician should be available to take the delivery, even if it's a vaginal delivery, because there is a very high risk of hematoma formation. We have suffered so much with these hematomas after dengue. That's all the message. Sorry, I overshot the time. There was so much to discuss.
Thank you so much, Dr. Jyotna. You have covered all aspects, because seriousness during pregnancy is definitely, we have to diagnose time, manage properly to save mother as well as the child. Because sometimes the patient maybe feel is a quite normal, she's not, and suddenly she collapse also. So you have explained everything very nicely. Thank you so much.
Thank you, ma'am.
Thank you,
Lakshmi,
Jyotna,
do you
for
want to go back?
wonderful.
Pardon, ma'am?
Moshmi, you are there, and I think you have been already introduced now. My net was froze. Pratik, you have introduced. I'd like to see that. So,
Do you want to complete your presentation? Is your network better now?
Moshmi,
Moshmi,
unmute
Yes, sir, I'd
yourself.
like to complete my presentation.
Okay, please go ahead.
Yeah.
fine.
Can I start my presentation?
Yeah, please. You can take 10 minutes.
Sir, I only spoke for 1 minute. So coming back to malaria in pregnancy, it is a major public health problem. Causative organisms, Plasmodium falciparum, most common cause of severe morbidity and mortality, Plasmodium vivax.
Click on the slide, ma'am.
Moshmi, your slide is not moving.
Slide is not moving,
Yes.
Dr. Mosby. See something
Wrong.
problem there?
Yeah.
Yes.
So according to the CDC, the malaria parasite has 3 cycles: the sporogonic cycle, the exoerythrocytic cycle, and the erythrocytic cycle. Malaria in pregnancy is a critical report. So any lab which diagnoses malaria in a pregnant lady has to notify the patient as well as the obstetrician. It is very dangerous in pregnant women and fetuses. It significantly impacts the maternal and fetal health, and disease is most severe in primary para. Pathogens of infection. The parasitic invasion of the erythrocyte consumes hemoglobin and alters the red cell membrane. This Plasmodium falciparum infected erythrocytes stick inside the small blood vessels of brain, kidneys, and other affected organs. The malaria parasites in the placenta impairs oxygen and nutrient transport to the fetus. Placental thickening and decreased transplacental nutrients and hormone production occurs, which leads to uterine and placental reduction in blood flow, leading to intrauterine growth reduction. And the sequestered parasites evade host defense mechanisms. What are the adverse effects of malaria in pregnancy? It is due to the high fever as well as the parasitization, leading to miscarriages, pulmonary edema, hypoglycemia, severe anemia, premature delivery, fetal growth restriction, stillbirth, and also maternal and fetal death. So malaria in pregnancy increases the risk of severe malaria, death from severe malaria, and pregnancy complications, as shown in the figure, leading to severe malaria, congenital malaria, and stillbirth. We'll come to that. So this malaria has, there are three categories. One is gestational malaria, which is infection or illness experienced during pregnancy. The second category is placental malaria. The placenta is the ideal reservoir of infection for this organism. And this is more common in regions with high malaria transmission. The third entity is the congenital malaria, where infection or disease affecting the neonates up to 28 days of age, excluding infection transmitted through the bite of infected Anopheles mosquito. This is vertically transmitted when malaria parasites cross the placenta or via direct contact at the time of delivery. Now, how do we diagnose? One is clinical diagnosis, the other is conventional microscopy, and there are rapid diagnostic tests. Conventional diagnosis is again fever, but with non-specific signs and symptoms with a broad differential diagnosis. Almost all patients have a history of fever. Now, how this fever presents? It is classically produces a 3-stage paroxysm progressing over an 8 to 12 hour period, consisting of rigors and chills, that is the cold stage, followed by fever, the hot stage, followed by sweating and resolution of symptoms. In severe cases, it produces prostration, impaired consciousness, coma, multiple convulsions, respiratory distress, pulmonary edema, circulatory collapse, jaundice, and hemoglobinuria. Conventional microscopy, we all know, light microscopy of thick and thin smears. How does it help us? It allows identifying the specific parasite, to quantify the level of parasitemia, to monitor the response to treatment, and all markers. This smear should be taken as soon as the diagnosis of malaria is considered. And this blood smear should be repeated every 12 to 24 hours for a total of 3 sets before excluding malaria. There are various rapid diagnostic tests also, like dipstick antigen detection, microscopy with fluorescent stains, DNA probes, and polymerase chain reaction. However, a positive diagnostic, rapid diagnostic test should be followed again by microscopy to quantify the number of infected RBC, that is the parasitemia, and to confirm the species and the stage of parasites. Imaging has a role in cases of splenic rupture. Now, coming to the management, treat malaria in pregnancy as an emergency. Treatment should be prompt and tailored to the gestational age and severity of disease. The goal of treatment is to relieve symptoms, eliminate parasitemia, and prevent recurrent disease. Admit pregnant women with severe and complicated malaria to an ICU, because delay in treatment can lead to the increased mortality and morbidity of both mother and fetus. So intravenous artesunate is the treatment of choice for severe falciparum malaria. Artesunate is a drug of choice for all forms of malaria at any stage of pregnancy, and usually they are well tolerated. Places where artesunate is not available, IV quinine can be given. Use quinine and clindamycin to treat uncomplicated Plasmodium falciparum malaria, and use chloroquine to treat Plasmodium vivax, ovale, or Plasmodium malarium. It is to be remembered that primaquine should not be used in pregnancy, and we can seek help from infectious disease specialists. Do not persist with oral therapy if there is persistent vomiting. We need to treat the fever with antipyretics and screen women for anemia. After 24 hours, if the patient is able to tolerate oral therapy, we can now change over to the oral ACT combination therapy. Now, what is the CDC criteria in case of complicated or severe malaria? That is, presence of one or more of the following: impaired consciousness, severe anemia, acute kidney injury, acute respiratory distress syndrome, shock, DIC, metabolic acidosis, hemoglobinuria, jaundice. In these cases, artesunate IV 2.4 mg per kg at 0, 12, and 24 hours, then daily thereafter. Later, it can be again changed to oral medication. Alternatively, quinine IV 20 mg per kg loading dose can be given along with 5% dextrose over 4 hours, and then 10 mg per kg IV over 4 hours. It is to be remembered that quinine is associated with severe and recurrent hypoglycemia in late pregnancy. In case of uncomplicated malaria, falciparum malaria, oral quinine 600 milligram 8 hourly along with clindamycin can be given. And in case of Plasmodium vivax, ovale, and malariae, oral chloroquine is given 300 milligrams 68 hours later. And in case of resistant cases, also we follow the same protocol. Now coming to CDC 2024 guidelines, in case of chloroquine resistant falciparum malaria, artemether and lumefantrine is given, along with either artemether or lumefantrine, because artemether is an essential, is a very good drug, clears parasitemia, but the effect is short lasting. So the partner drug lumefantrine actually helps in clearing the parasitemia. And this can be given along with quinine and clindamycin. Now in pregnancy, we also need to do the fetal monitoring hand in hand along with the anti-malarial therapy. So ultrasound has to be done to assess the amniotic fluid volume, fetal size, and fetal well-being. In late pregnancy, fetal monitoring should be initiated before treating with quinoline therapy so that the effects of the disease can be distinguished from those of the drug toxicity. So early obstetric intervention may be considered for the benefit of mother and fetus at the discretion of the obstetrician. Nevertheless, it is not an indication for induction of labor. So how do we monitor? The hemoglobin, hematocrit, electrolytes, platelet count, glucose, lactate, blood gases, and along with the coagulation details have to be monitored. The level of parasitemia in response to the therapy also needs to be monitored. In case of severe or complicated malaria, careful attention should be given to prevent pulmonary overload. Monitoring of central venous pressure should be considered in critically ill patients, careful fluid balance, and also careful monitoring of serum potassium levels with appropriate supplementation as and when needed to correct the acidosis. Blood glucose should be checked every 6 hours and 50% dextrose administered when needed. So the complications mostly seen in Plasmodium falciparum and Plasmodium knowlesi, cerebral malaria, epilepsy, motor visual deficits, edema, ARDS, cardiogenic shock, renal failure, splenic rupture, DIC, hemolysis, severe anemia, or death. Supportive measures can be given in critical care unit, a multidisciplinary team approach in case of coma, using a Glasgow coma score, taking care of ABCs, hypoparexia with tepid sponging, and convulsions with anticonvulsant therapy. Hypoglycemia, take care of the blood sugar levels. Severe anemia, we need to do the blood transfusion. Coming to the obstetric management. In severe malaria, complicated by fetal compromise, a multidisciplinary team approach consisting of intensive care specialist, infectious disease specialist, obstetrician, and immunologist is required to plan the optimal management, because it can lead to preterm labor, fetal growth restriction, and fetal heart rate abnormalities. Stillbirth and premature delivery in malaria are best prevented by effective and anti-malarial treatment. Prognosis: pregnant patients with malaria have increased risk as discussed, and those with parasitemia more than 20% have a high risk of death. The prevention, the ABCD approach, that is the awareness of risk, bite prevention, chemoprophylaxis, and diagnosis and treatment, which must be prompt. There is intermittent preventive, I'll just take a minute. There is intermittent preventive treatment in pregnancy with sulfadoxine and pyrimethamine initiated in second trimester. There are insecticide-treated bed nets and indoor residual spraying, also health education and community awareness. There is an entity called vertical transmission of fetus, which occurs particularly when there is infection at the time of birth and the placenta, and the blood film is positive for malaria. All neonates whose mothers develop malaria in pregnancy should be screened for malaria with standard microscopy of thick and thin blood films. An infection of newborn can occur despite appropriate treatment in the mother during pregnancy. So thank you, ladies and gentlemen. Sorry for the problem in my network. Thank you.
Thank you very much, Dr. Moshmi. Excellent talk, and apologies to the audience for the frequent internet issues. We have with us all the way from the US, Professor J.B. Sharma, and sir is going to be speaking to us on tuberculosis in pregnancy. He has shared his presentation. Can I request the backend team to please share the presentation? Sir will speak.
Okay.
So let's introduce Dr. J.B. Sharma, who is head department of FOGSI. Yes. Yes, Pratibha, you are there.
Thank you for this opportunity, madam. And now we have come to the tuberculosis in pregnancy that really requires prompt diagnosis and treatment to avoid serious risk. And who can be the better person than Dr. J.B. Sharma, sir, to speak on this?
Thank you.
And he is, so let me introduce him. He is the head of department of FOGSI in Yashoda, Multi-City, Indrapuram, NCR. And he's also was the former professor and head unit in the department of FOGSI, AIMS, New Delhi. He had lot of positions he has held and lot of achievements to his credit. And he was also the past chair of Eurogyne FOGSI committee, Eurogyne committee FOGSI. So with this, I will request sir to start his presentation. Over to you, sir.
Thank you. Thanks a lot, Dr. Pratibha Madam, Dr. Jaiswar Madam, and special thanks to Dr. Sadhana Madam for inviting me from USA and Dr. Pratik Tambe and all the ICOG chairperson.
Sheila
So can
Mane
my...
ko bhul gaye?
Of course, madam, Dr. Sheila Mane, madam.
Noted ICOG chairperson.
Yes, Dr. Sheila Mane, madam, everyone, and Ashok Kumar, and yeah, thank you, madam, thank you. Yeah, so it's actually morning in the USA, and I'm, grandfather, so just a little bit. So nice, yeah. So as I heard both the presentation, Dr. Josna Suri and Dr. Malaria and pregnancy also, they were excellent. So I'll be talking about tuberculosis in pregnancy now. So next slide, please. So just a little bit about, as a source, WHO has come out with the guidelines on antenatal care for positive pregnancy experience. So I just like the readers, they can go to these guidelines, though I'll be taking material from them from CDC and from our own publication. Next slide, please. Yeah. So tuberculosis in pregnancy, basically the key points in CDC also there are guidelines. So there are special considerations while testing for and treating inactive TB during pregnancy. Actually, this is more logical for USA population. In India, we are not normally testing for screening for this tuberculosis. Only active TB we take care in India. Next, please. I'll be going to that, yeah. So now this was the review we published in European Journal of Obs and Gynae. So I have, taken some material from that also. Next slide, please. So now I'll be coming to the main presentation. So tuberculosis in pregnancy, basically TB disease during pregnancy is treatable and curable. That's what I want to highlight. And most women can deliver healthy babies if managed properly. So why TB in pregnancy matters? Pregnancy lowers immunity slightly and latent TB infection may reactivate. So there are two conditions. Basically, one is active TB, like active pulmonary TB or any active extrapulmonary TB. But there is one inactive TB, also latent TB, which can also become active during pregnancy because of the lower immunity. That is important. And untreated TB, it is the basically untreated TB which is associated with main complications. So if TB can be treated, diagnosed timely and treated timely, then outcome can be almost as good as the normal background population. So maternal illness and complication we have to treat. It can cause, if untreated TB, then it has all the complications, and they tend to be more in pregnant women than non-pregnant women. So there can be maternal illness complications, low birth weight in the fetus, preterm delivery, and really congenital TB in newborn can happen, just like Dr. We heard about malaria and pregnancy. Next, please. Okay, so what are the symptoms of TB in pregnancy? Usually, it is pulmonary TB or extrapulmonary TB. It will remain same in pregnancy as it in non-pregnant state. Only thing, certain signs, symptoms we may think that they are because of pregnancy, like malaise and all. So that you have to be little bit high suspicion has to be kept. Otherwise, they are same as in non-pregnant state. Like persistent cough for more than 2 weeks, we have to check for tuberculosis. Fever, especially evening rise, night sweats, weight loss or poor weight gain, loss of appetite, unexplained, fatigue, hemoptysis sometimes, and symptoms related to a site. In case of extrapulmonary TB, so that means there may be swelling in the neck if there are cervical lymphadenopathy. Chest pain can be there in extrapulmonary TB, like pleural TB, and and other complications or like alternate constipation and diarrhea in case of GI tuberculosis. And of course, meningeal TB, there will be CNS symptoms, and similarly, miliary TB, there may be generalized symptoms. Next slide, please. Okay, so what is the diagnosis? Diagnosis is almost same as in non-pregnant state. Diagnosis is totally safe in pregnancy, and all standard tests can be used with precautions. They're like just like we are a little scary of doing X-ray chest or CT chest, but otherwise even they can be done because the radiation is very low. So, but for pulmonary TB, usually we do sputum smear microscopy, and WHO has recommended rapid molecular test like CBNet, same name as GeneXpert, TrueNet again, same. So they are preferred on the sputum microscopy, and culture, liquid culture if available. Chest X-ray with abdominal shielding can easily be done. Don't hesitate in doing that. And for extrapulmonary TB, it is based on extrapulmonary site. Basically, like ultrasound, MRI is totally safe. Biopsy, fine needle aspiration from or fluid analysis can be done. Like there is a cervical lymph nodes posed in the neck, then we can easily take FNAC from there, totally safe. And molecular tests are preferred like CBNet or GeneXpert or TrueNet can also be done on the sample from that. Next slide, please. Okay, so TB disease in pregnancy may present with diagnostic challenges because of often non-specific nature of early symptoms or like malaise, fatigue, which may be attributed to pregnancy or suspicion of TB. So this is the important, like patient may be having little bit malaise, little bit weakness, and we say, oh, well, these are normal signs of pregnancy. But usually like chest symptoms, cough, expectoration, fever, evening rise, etc., they will be more specific of tuberculosis. So keep a high index of suspicion. That's what I want to highlight. Next slide, please. So what is treatment? Treatment is totally safe in pregnancy. If there is delay in diagnosis and treatment, then there could be adverse maternal outcome like preterm labor, fetal growth restriction, and even stillbirth. Similarly, severe forms of TB like disseminated disease, miliary tuberculosis, or multispectrum disease, they are associated with poor outcome. So if timely diagnosis is done, timely treatment is done, the outcome may be almost as normal as in the background population. But if we delay the diagnosis, if we delay the treatment, and or if it's a severe form of TB, then the outcome tends to be poorer for both mother and fetus. Next slide, please. So this is the integrated. Next slide again. Can you? Yeah. So this is the algorithm. Don't. It appears to be a little bit more, but let me go on the right side first. So drug sensitive TB. Most commonly, we will be dealing with the drug sensitive TB in our practice, like pulmonary tuberculosis. In that case, if you go on the right side, so my MTB positive and rifampicin resistant not detected. So that means it's a drug sensitive pulmonary tuberculosis. Even extrapulmonary TB, the treatment is to HRZD. That means 2 months of daily isoniazid H, rifampicin, pyrazinamide, ethambutol. So daily for 2 months is to be given. Alternate day is not to be given anymore. And then followed by 4 months of HRE. That means isoniazid, rifampicin, ethambutol are given daily again for next 4 months. So total 6 months therapy is to be given in case of drug sensitive tuberculosis. Now, if there is drug resistance to only isoniazid, not rifampicin, in that case, we have to give the drug 6 to 9 LFX RZE. That means we still can RZE, rifampicin, isoniazid, and ethambutol have to be given. And now instead of isoniazid, we give levofloxacin. And the treatment may go from 6 to 9 months in this case. And if we go to the left hand side, that means that TB resistance, then the BPAM therapy usually avoided in pregnancy. So we have to give 9 months to 1 year therapy, which I'll be discussing the next slide, please. Next, please. Okay. So this is the basically treatment we can give. Linjolid, clofazimine, ITD. We will be discussing more in the next slide. Next slide, please. Yeah. Okay. Again, next slide, please. Okay. Next, please. So BPAM regime is usually avoided in pregnancy. So this is the basically, drug resistant TB. Again, we can go to the next slide, please. I'll have more in the text form. Yeah. Okay. So all regimes can be given safely in pregnancy for drug resistant, accepting BPAM regime, which we avoid in pregnancy because the drugs can cause teratogenicity and later on effects on the fetus. Next slide, please. Yeah, so this is the so same thing basically. I already said it. So for WHO as well as NTEP, National Tuberculosis Elimination Program of India, recommend I already discussed 2 months of HRZD daily and followed by 4 months of HRE for drug sensitive tuberculosis. And pyridoxine vitamin B6 supplementation should be given as isoniazid can cause peripheral neuropathy, which can be more in pregnancy. And vitamin K to be given to newborn. We are giving anyway to all newborn, but they specifically because rifampicin can cause theoretical risk of postnatal bleeding in the infant. And liver monitoring to be done because the drugs can cause liver toxicity. Next slide, please. Okay, so this is the standard regime, totally safe. What I want to highlight, even in first trimester, even if the patient comes to a 6 weeks of pregnancy, 8 weeks of pregnancy, we have to give the drug. Please don't delay the treatment to 12 weeks or so. Some people say they don't give in first trimester. All the 4 drugs, HRZD, are totally safe in pregnancy, even in first trimester. The delay in diagnosis and treatment causes more complication than that. Next slide, please. Okay, now I won't go into too much detail of MDR TB in pregnancy. In that case, we have to take the opinion of the expert, but little bit that it requires management under supervision of TB expert. Many second line drugs have limited safety data in pregnancy, while primary drugs for HRZT are totally safe in pregnancy, but MDR TB drugs have limited safety data and treatment is individualized based on
Some network
more
issue. Let's
little
wait
bit.
for it.
Next slide, please. Yeah. Okay. Next slide, please. Yeah, okay. So now drug-resistant TB as per NTEP and WHO, shorter MDR regimen, that means 6 to 9 months of bedaquiline and 2 months of linezolid and 4 to 6 months of levofloxacin, clofazimine, pyrazinamide, ethambutol, isoniazid. So accepting for rifampicin because we label the drug resistant when patient is resistant to rifampicin. So patient is still sensitive to pyrazinamide, ethambutol, and isoniazid high dose. This is high dose to be given. Along with we have to give 6 to 9 months of bedaquiline, linezolid, levofloxacin, and clofazimine. And then linezolid is preferred. Ethionamide is given after 32 weeks of pregnancy only for intolerance to linezolid. Other that's not a part of regimen. And it is followed by 5 months of levofloxacin, clofazimine, and pyrazinamide and ethambutol. So total about, I mean, we have to give the treatment is 9 months to 1 year. And longer all oral MDR regimens can also be given, like 6 to 9 months of bedaquiline, 18 to 12 months of levofloxacin, linezolid, clofazimine, and cycloserine. They can be given, and then pyridoxine to be given to all patients. Vitamin K to newborn, as we have already discussed. Sputum culture to be done, and some of these drugs like bedaquiline can cause cardiotoxicity, so we have to monitor the patient for that. And CBC, LFT, KFT monitoring to be done because some of these drugs, most of the drugs can be hepatotoxic, and sometimes they can cause renal toxicity also. Next slide, please. But for whenever we are giving drug resistant TB, don't start treatment alone. You take the opinion of the expert, TB expert in these cases. Next slide, please. Okay, status of BPAM regime is normally non-pregnant state. BPAM regime is the best regimen for drug-resistant TB, but there is no safety data of BPAM in pregnancy, insufficient data, so it is not recommended in pregnancy. The treatment which we have to give, I have already discussed above. So avoid BPAM regime in pregnancy. Next slide, please. Yeah. And this can be given if the mother agrees for MTP and drug resistant, then after MTP we can give BPAM regime also, of course. But if the patient is continuing pregnancy, then avoid this. Next slide, please. Okay, so drugs which are to be avoided in pregnancy, some anti-TB drugs can harm the fetus, like all mycins, streptomycin, kanamycin, amikacin. They can cause fetal deafness and ototoxicity, so we have to avoid them. Fluoroquinolones use only for MDR-TB with specialist advice. They are not absolutely contraindicated relatively, but can be given, but if after consultation with a specialist. Ethionamide is contraindicated, but if need be and patient cannot tolerate other drugs, then we can start ethionamide after 32 weeks of pregnancy, not before that. Kanamycin, capreomycin are no longer used, but they are also contraindicated in pregnancy. So otherwise, other drugs, I mean, they can be easily given. Next slide, please. Yeah. What are the effects on the fetus? If mother is treated properly, even in first trimester, that what I want to highlight, even if patient is 6 weeks, 8 weeks pregnancy, you have to treat the patient, especially drug sensitive TB. There is no risk at all. RHZ totally safe. That's what I want to highlight. So most babies are healthy. Breastfeeding is allowed if the patient and mother is actually open case of pulmonary TB in lactation phase. Usually, if she was in pregnancy, she would have already become sputum negative, so there is no issue at all. But if you detected it just at 40 weeks of pregnancy and patient is open sputum positive, in that case we can cover her mouth, with the mask and all. Still, she can breastfeed the baby. So it doesn't go. The drugs don't go in breastfeed, and the bacteria also don't go in breastfeed. And baby may receive preventive therapy as per usually the transmission is from mother to the baby later on. Not usually congenital TB is very rare. But untreated TB may cause, so it is the delay in diagnosis, delay in treatment, or not starting treatment, or hesitation on starting treatment, that it can cause low birth weight fetuses, prematurity, stillbirth, and congenital TB very rare but very serious. Next slide, please. We'll be having a slide on that. So if mother has active TB, baby evaluated for TB and assessed to rule out active TB newborn by the specialist. So again, that is the pediatrician will look for that. And the baby has full-fledged, I'll just take 1 minute. And baby has full-fledged TB, then baby has to be treated fully for that. So that is beyond the scope of this lecture. The neonatologist will treat that. So treat baby with ATT for TB disease in the baby. But otherwise, the TB preventive treatment for TB infection with isoniazid can be given for 6 months or so. And neonatal BCG vaccination routinely given as per guideline. So that is one heard. And breastfeeding is totally allowed in most cases. And especially mother should wear mask if infectious. But usually because she was positive TB in pregnancy, so we would have treated her. She is negative now, open. She is not open case, so she can easily breastfeed. Only thing, if she is active TB at present, then she should wear mask. Next slide, please. Just I'm about to finish. Yeah. So neonatal TB should not be delayed diagnosis and treatment. And patient if confirmed TB in the neonate, then we have to we have to treat it as per treatment of the neonatal TB, just like full 6 to 9 months course of RHID and all, depending on the type of TB. Next slide, please. Just I think just next slide, please. We have already done that. Next, again, next, please. These are our publications. Next, please. Next, please. We have already done that. Next, please. Okay, so what I want to highlight that TB treatment is totally safe in pregnancy, diagnosis and treatment, even in first trimester. Do not stop medicines after patient becomes pregnant. Early diagnosis improves outcome, and multidisciplinary care is ideal, especially for MDR TB. Thank you very much, and I thank Pratik and all the team, Dr. Sadhana Madam and Dr. Sheila Mane and all for the opportunity. Thank you. I will be happy to answer any question.
Thank you. Thank you so much, Dr. Devi Sharma.
Thank you, madam.
No other than you can be so expert in the tuberculosis. You have lots of work in tuberculosis.
Dr. Jeswar, you also did a lot of thesis, PhD also on TB, so we have done
And
work together.
Definitely, sir, you have done a lot.
And thank you for logging in all the way from Florida. Really appreciate it. And it must be 3-4 in the morning there right now.
Thank you. Okay.
Good morning. Good morning to you, Dr. Sharma.
Thank you, Sadhana Madam. Thank you.
And congratulations also.
Yes,
Dr. S.
my-
N. Tripathi is with us. Dr. S. N. Tripathi, ma'am. I have seen her, if it is, she is there, because she has done the extensive
Oh,
work.
madam, in fact, we got stimulated to work because of
Yes.
Dr. Tripathi, ma'am, and her husband work. No, they have done so much work.
But
We
I am
salute
seeing,
them.
yes. So I'm seeing her name, but actually I'm not able to see. So let's move
Even
on.
then, we salute her for the great work she had done, man, and blessed.
Yeah, definitely. I know her work, and in fact, so focused topic. She writes books, excellent books. Yeah.
Thank you.
Yeah.
So there are few questions, Dr. J.B. Sharma, for you. So
Yes,
we
madam,
request
most
you
welcome.
to answer in the chat so that we can go ahead with the next session.
Yeah, I'm not able to see the question. Can someone come? Tell me the question.
Chat box, you have to click.
Oh, Pratik, can you just see the question and...
One question is that can the MTP medical abortion kit can be given and mifepristone can be given to patient on anti-tubercular treatment? So I think
Yeah,
that's
sure.
the
They
first
can be
question.
given. No issue at all. Absolutely.
Yes.
They can be given.
See, mifepristone, only one contraindication. If the patient has IHD, cardiac disease, one has to be careful with mifepristone.
Yeah. For TB, there is no contraindication.
Yeah.
Absolutely.
So next session, Maushmi or Pratibha, you start the next session.
Maushmi, hello.
Yes. Thank you, madam. Thank you, dear chairperson. Tripathi madam, actually, she was very positive about it in the morning, but now she's not picking up the call. Dr. Jaiswal and Dr. Pratibha Singh madam for chairing the session, and excellent talk by Dr. Jyotsna Suri and Dr. Sharma. Thank you, sir. Moving on to the fourth session. The fourth session is on viral infections in pregnancy. I welcome Dr. Anju Soni, Dr. Sukanta Mishra, and Dr. Somini Gangaraju as chairperson. Soni, madam, she is the HOD gynae of Sony Group of Hospitals.
And
some voice.
Yeah.
It is in your end or the Maushmi end?
I think it was Dr. Somini, ma'am.
So I would like. Shall I take?
Yes.
Yeah, please go ahead.
Yes, Pratibha.
So it's my proud privilege to introduce Dr. Sukanta Mishra. He is a professor and head in VIMS RK MSP Kolkata. So welcome, sir. He was the president of Bengal Obs Society. And Dr. G. Next slide, please. G. Samani. She is professor and HOD Obs and Gynae in AMC Vishakhapatnam. So welcome our chairpersons. Now I'll request our chairpersons to kindly introduce our speaker. Doctor, I think.
Good evening, all.
I think
It's a very
nobody is there. So I request Dr. Sheila Mane, madam, to kindly introduce our speaker.
Yeah.
So very nice to see Dr. Girija. All of us, we know her. She is working with Justosis very much. She was organizing secretary for conference in Pune. Then she's a steering committee member of World Organization of Justosis. And she is a president-elect of Justosis India. Areas are, I think, high-risk pregnancy, advanced patient management and medical interpretation, research and medical education, holistic wellness and lifestyle modification, academic leadership and mentorship, and a good friend of all of us and previously vice president of FOGSI. And we welcome you.
Over to you, madam.
Just 1 minute, Nilima. Dr. Manju Verma is there because I think Dr. Tripathi was also there. So please allow them to unmute.
Okay.
Just because Dr. S.N. Tripathi was also there.
Very silent.
Even Dr. Somani is there. She is unable to unmute herself.
So please, at back end ICOG office, kindly see. Because Dr. S.N. Tripathi was also there.
Ma'am, they are already
Yes.
closed, ma'am.
Yeah.
Okay.
Good evening, all. It's a very nice opportunity to spend time with you, all academicians and good sessions. Especially these viral infections during pregnancy are more important because you started the immunological changes occur in the pregnancy and the susceptibility is also more. The main aim for us is to prevent the fetal transmission. That is why we are screening the seropositive nature for this hepatitis virus and all, and HIV virus. These are the two important topics we are going to learn now. Are you able to hear me, ma'am?
Yeah.
Okay.
Yeah.
You're audible. You're audible.
If somebody has logged in from 2 devices, please mute one.
Yeah.
Otherwise, there will be echoing.
Over to Girja, madam. Over to Girja, madam. Yes.
Hello.
Girija, hello.
माझं दिसतंय का?
दिसतंय. Very much.
Okay, thank you. Thank you so much.
Audible and visible. Please go ahead.
So today I have been given an opportunity in this wonderful ICOG certificate course to speak on influenza and COVID-19. I really want to congratulate the ICOG team for giving me this opportunity and for hosting such a wonderful certification course. And we require to know about this as OBGYNs, especially because pregnant women face a very high risk of severe influenza and COVID-19 due to changes in immune, respiratory, and cardiovascular physiology. And there's a whole body of evidence now available to us with the recent pandemic experience that we all had. And flu had been really bothering us for a long period of time. But there has been a phenomenal understanding towards this particular disease from 2009 itself. Both these infections are linked to maternal complications, ICU admissions, and adverse perinatal outcomes, including preterm births and stillbirths. Now, why pregnancy is increases the severity of both these infections? This is because of the immune and the respiratory shifts which happen in pregnancy, which raise the infection risks. So what happens? There's a reduced cell-mediated immunity, there's decreased ability to clear viruses efficiently, and there is increased susceptibility to respiratory pathogens, especially in these women. And this will therefore give rise to a greater systemic inflammatory stress, leading to pneumonia and sepsis. And especially in COVID-19, you will also have nearly 2 times higher possibility of getting preeclampsia. Now, viruses take advantages of this particular respiratory vulnerability, especially during pregnancy, because of the reduced lung capacity, impaired lung expansion, and respiratory distress coping difficulties. There is always a higher oxygen demand, and it keeps on increasing throughout the entire pregnancy. And especially with viral pneumonitis, influenza, COVID-19, there is very rapid lead to hypoxia. And therefore, there's a greater risk of respiratory failure with COVID-19, H1N1, needing ICU hospitalization and greater need for respiratory support. Especially in the third trimester, this risk is at its peak. I still remember our wards in Bharati Vidyapit where we had associated with the Pune Corporation and we had dedicated wards for H1N1 that time, and it was nearly more than 50 to 60% admission were pregnant mothers. And therefore, one has to be absolutely looking at this, because what happens is in COVID-19, severity is maximum in the late pregnancy because diaphragm elevation further compromises the ventilation of the mother. Now let's look at all of them one by one. Influenza and pregnancy, the recent evidence and updates. We are well versed, very well experienced, but what's happening right now? Pregnant women are significantly more likely to be hospitalized with influenza than non-pregnant peers. And it was found in this particular study in the United States, about 2,697 pregnant women hospitalized were admitted, 5% to the ICU, 2% required mechanical ventilation, 6% developed pneumonia, and 0.3% died. Now, what is also important to understand this viral infection is the very severe pyrexia, because fever in early pregnancy is linked to neural tube defects and adverse fetal outcomes. How does this impact the fetal development is beautifully depicted in this particular poster. Critical timings being the first trimester, especially the weeks of organogenesis, there is a higher possibility of structural defects because of increased vulnerability of the embryonic plate and those tissues. Neural tube defects, especially spina bifida or congenital heart disease, probably the risk is increased when these febrile illnesses are for a long period of time. And the threshold of concern usually is not only the temperature, but also the duration, 102 degrees Fahrenheit or more. And if it is sustained for 24 hours or more, there are high chances that these problems can happen. So it's very important that brief lower fevers generally are less concerning. So we should not be worried about that. But whenever the high grade fever is there, we have to do everything to try to reduce the febrile attack that the woman is having. And it's always to remember best that acetaminophen often is the safest during pregnancy, and promptly managing high fever can reduce risk, and it's important to seek medical advice for these. Prevention always is the best cure, and this is what the ACOG and the CDC updates say. Universal influenza vaccination is recommended for all who are or will be pregnant during the flu season of September-April. Inactivated or recombinant vaccines only during pregnancy. LAIV and intranasal is not approved in pregnancy but allowed postpartum. And co-administration with Tdap RSV or COVID-19. RSV is also sitting to get inside our country, but it is very, very commonly given now in the United States of America. And this is safe and does not reduce efficacy. Now, the timing of vaccination, give as soon as available any trimester. Earlier vaccination in July, August may benefit third trimester pregnancies for neonatal protection. Now, why it is always better to give this particular vaccines, especially anytime they're safe? That's one. In the second trimester onwards, it's important because it is known to maximize antibody transfer to the fetus, especially from 24 to 26 weeks onwards. Placental IgG transfer peaks in late pregnancy. Vaccinating before or early in the third trimester allows more time for high antibody levels to develop and cross to the fetus. It also ensures maternal immunity before flu circulates, and therefore in July-August, it will give mother and protection which will help in ensuring immunity established by delivery. Also, we all know that the infant's first 6 months of vaccination program doesn't include this, but the antibodies which are passed to the baby will protect them. And additionally, early vaccination boosts the maternal antibody levels, which continue to protect the newborn through the breastfeeding phase. Now, if the patient gets influenza, it's recommended that we give empiric oseltamivir, and it should be started immediately when influenza is suspected, and there's no need to wait for any test results. Early treatment, less than 48 hours, reduces the need for ICU care and maternal mortality. This is the evidence from the H1N1 pandemic and the seasonal influenza. And neonatal protection awarded by maternal vaccination and reduction in the infant flu-related hospitalization is nearly about 40%, which is quite satisfactory. Now, coming to the COVID-19 in pregnancy 2025-26 critical updates. Pregnant patients with COVID-19 have 40% higher risk of serious complications or death versus infected pregnant individuals, markedly higher rates of mechanical ventilation, thromboembolism, cardiac complications, and especially this is more severe in the third trimester. COVID-19 is known to double the eclampsia risk. Adjusted OR is about 2.1, increased risk of stillbirths. If infected and in utero transmission is rare, but it properly is because of the hypoxia and the thromboembolism sequencing because of which the stillbirths would happen. And in utero transmission is rare and congenital anomalies are not known to be increased. But in the early parts of pregnancy, COVID-19 was attributed to miscarriages, probably because of the high fever. Now, if you look at the COVID-19 vaccination in pregnancy, the ACOG strongly recommends vaccination against COVID-19 during any trimester, postpartum, and while lactating. And vaccination is known to reduce all the serious consequences, and especially preterm births, which were found both in the Delta and the Omicron periods. And maternal vaccination is shown to provide passive immunity for the first 6 months of the life of the infant. Now, the natural question comes, is it safe? Now, data from more than 1 million vaccinated pregnancies show no increased health risk to mothers or infants, and COVID-19 vaccines are not associated with infertility. So if you look at the global policy, some regions temporarily withdrew routine pregnancy recommendations, but CDC in May 25, but ACOG reaffirmed that vaccination is essential. And I have a few patients coming from the US, they have been given these vaccines. The official MOHFW, that is our Ministry of Health and Family Welfare guidance for COVID-19 vaccination pregnancy, continues to be there on night and on the website, and states that pregnant women may be offered the vaccine at any stage if available. However, since the mid-2023 in India, COVID vaccination program wound down due to the fact that there was cessation of government procurement because we do not have access to these vaccines anymore, expiration of the earlier vaccine stocks, no new booster policy, and therefore the manufacturers halted the production due to low demand. So clinical management summary of both these influenza: vaccinate all pregnant patients early in season, start oseltamivir immediately when suspected, reinforce newborn protection via breastfeeding antibodies, and COVID-19 vaccinate in any trimester, boosters per updated guidance, early triage for at-risk groups, especially those who are obese, asthmatic, and who have obstructive sleep apneas, and counsel regarding preeclampsia risk, fetal surveillance, and symptoms of respiratory distress. These are the various references that I referred to, which are CDC, the ACOG, and many other and publications which happened during the COVID time. Thank you so much.
That was wonderful. Yeah.
Over to Manju Madam. Manju Verma Madam, if you can conclude.
Hello. Very nice and crisp talk, Girija. Very nice.
Dr. Manju Verma, your comment.
Let Dr. Sheila Mani conclude. No problem. No problem. Okay. Carry on, Dr. Sheila. Carry on.
Yes. Dr. Sheila, your comment.
Yeah, madam, your
Dr.
comment.
Sukanto is also. Dr. Sukanto.
Anybody can comment.
Yes.
Actually, sir.
As a matter of fact, if I'm allowed to say.
Yes, sir. Yes, sir.
Okay. As a matter of fact, we always know that Dr. Girish is a wonderful speaker and he has compiled the comprehensive topic in such a beautiful and short span of time with all the evidences that she has accumulated. Wonderful. And I think if there are any questions, just put the questions in the chat box and that might help the organizer and the speaker as well to complete this session in due time. Thank you.
Thank you.
And I must thank Dr. Sheila Mane, Dr. Sadhana Gupta, and Dr. Pratik for inviting me to be a part of this wonderful scientific session. I wish
Thank you, Dr. Sukanta, for appreciating.
Yes, Dr. Girija. Thank you very much.
Thank you, sir. Now, I think Sadhana Madam will be the next speaker.
Yes.
Yeah, so I'll request Dr. Manju Verma Madam to kindly introduce Sadhana Gupta Madam. And she will be talking on hepatitis.
Very good evening to everyone. And my special thanks to, of course, Sadhana, Dr. Sheila Mani, Dr. Pratik Tambe, and everybody who is an official of ICOG to make me a part of this wonderful webinar on the infection in pregnancy. And viral infections, as you know, is very, very important. And it is very difficult to prove, you have indirect tests for saying that this may be an infection. But, we have got a very, very, great speaker with us as Dr. Sadhana. She is now the ICOG vice chairperson, and she has held a number of posts, FOGSI representative to FOGSI vice president, UPCOG vice president, and she has got a number of awards to her credit. APJ Abdul Kalam.
It's okay, ma'am. It's okay,
a long list of awards. And I think Sadhana, you're going to do a good justice for this topic which has been given to you. Congratulations again, Dr. Sadhana. I think the platform is yours now.
Thank you, ma'am. It's a great honor to be introduced by you, who has been always my inspiration and my teacher. So I'm sharing my screen, and is screen visible?
Yes, ma'am.
Pratik?
Yes, ma'am.
Yes, ma'am. You can go full screen. Perfect.
So
it's visible.
I will be taking in next 15 minutes how hepatitis in pregnancy is impacting us in the magnitude as well as the criticality. I will start that we all should stand up for peace in a very, very violent and the turbulent world, because only the giving value to life makes the medicine meaningful. So viral hepatitis is a widespread infection which affects both pregnant and non-pregnant population, and there has been more than 10 million new infection and more than 1.34 million deaths due to viral hepatitis. Most common responsible are hepatitis B and C for these deaths. And the point to be very, very caution is that there is trend in increase of 15 to 20% of death related to viral hepatitis. And we have to bridge a lot of gaps in detection of disease as well as the treatment. So it is not the hepatitis A. We have all alphabet A, B, C, D, E. The important thing which I wish to communicate that these viruses have an affinity for liver cells. But actually the hepatitis is the body reaction to their infestation. So it is an immunological response to these virus infection which cause hepatocellular necrosis. However, beyond hepatitis A, B, C, E, and I will just touch on the D and G also, there can be the non-hepatotropic virus who don't like the hepatic cell, but they can cause the hepatitis due to their overall acute viral illness manifestation. So viral hepatitis in pregnancy, why we are concerned? Because it is a common infection. It has the two issues. First is that it can have the acute complication. Secondly, it can lead to the chronic liver disease for both mother. And the third, very, very important, where obstetrician need to intervene, that the prevention of maternal to child transmission of that virus. So we need a very comprehensive and multidisciplinary approach, how to identify by proper screening protocol. Can we have the benefit of preventive strategy, how we treat infection, immunoprophylaxis, and encouragement of safe breastfeeding. So obstetricians have much to do. And the teaching is all about making the complex things simple. And I will just like to make the topic very, very simple. So when we have the patient with the viral hepatitis, a pregnant woman, what we should do? We should listen to the patient. So we have a wonderful talks by the previous speaker. Any fever, malaise, upper abdominal, right quadrant pain. So it is a proper pure surface anatomy, that upper abdominal right quadrant pain, nausea, vomiting, and a little bit of dark colored urine. You should be very, very alarmed that this pregnant woman can have hepatitis. And you have to palpate, because now in the time of imaging, the doctors are losing that art of palpation. So the tender liver and hepatomegaly, right at the first contact, we can say. The investigation are pure classical ALT, GPT, GOT. Just I want to highlight that ALT is typically higher than AST because the ALT source is in the liver, but the GOT source have got the other, beyond liver, they have the source of the origin. You have to say that it is a chronic infection or it is an acute infection, because the chronic phase may be associated with minimal symptom, but the acute phase have got the alarming symptoms. So diagnosis is often from routine screening or routine investigation of any unexplained abnormal liver function. So we do routine and it is bilirubin is raised or the GOT, GPT is raised, and then we think. So let's learn and relearn. So hepatitis A, the low, what the world says us, it is a low middle income countries, but we must have that objection to all these words which the world puts on the different countries. But important thing is that the transmission is the orophycal route, and hepatitis A is quite common in our country. Important thing is that the infection during pregnancy may be associated with higher risk of maternal complication. So it is important, but per se pregnancy has no negative impact on course of hepatitis virus infection. Another important thing is that the lifelong immunity is acquired with HIV, IgG. So if one is infected, usually it confers the lifelong immunity. How can it affect the course of pregnancy, preterm labor, from abruptio and antepartum hemorrhage? But sometimes the intrauterine transmission of the hepatitis A can lead to neonatal meconium peritonitis. So we should do a prenatal scan to screen for polyhydramnios and the fetal ascites. Only in certain situations when there is a severe liver dysfunction in third trimester, sometimes we can take decision of early delivery. Management is purely supportive, hydration, nutrition, antiemetic, antipyretic. Usually the disease typically resolves in the 6 to 8 weeks, but can sometimes progress to fulminant hepatitis with hepatic failure and encephalopathy with need of even liver transplant. There is no established antiviral therapy for hepatitis A. Only the few drugs like sofosbuvir has been being researched for the anti-HIV effect. So our main course is sanitation, passive immunoglobulin prophylaxis. HIV vaccine we can give to pregnant woman if she is traveling to any place where the hepatitis A is endemic, and breastfeeding with the woman with the HIV is relatively safe. So be careful, if the woman is traveling to that place, you can offer the hepatitis A vaccine very, very safely. Now, hepatitis B, which is the main domain of the obstetrician, and we have got a lot of discussion and a lot of recommendation. Yet hepatitis B is affecting more than 240 million people worldwide. Important thing is that the vertical transmission, that is from mother to fetus, contributes to almost 50% of chronic infection. And then these fetus who are born hepatitis B positive, they become the source of the horizontal spread of the hepatitis B. So the prevention of MTCT by obstetrician has to be very strategically targeted so that we can interrupt all these vicious cycles. So we have a great role to play in the prevention and reducing the incidence of hepatitis B. Effect of hepatitis B on pregnancy is very minimal, but in chronic disease which is present already, the altered immunity can increase risk of HBV flare-up. So even the chronic woman can have the HBV flare-up, which can be up to 6 to 14%. But fortunately, these flares are mild and self-limiting, and it is reasonable that whenever we find any woman with the hepatitis B positive, we monitor the liver function test with the ALT level. So this is important. I will just touch on the SMFM guidelines, who say that the triple testing, which is we are not doing in our clinical practice, but yes, sometimes it can help. There is no definite cure for hepatitis B. Mainstay remains viral suppression and immunization. And a very, very important step which every obstetrician must know, when the hepatitis B viral load is more than 2 million IU/MI, or what we say 5.3 log, the person, the pregnant woman, should receive tenofovir prophylaxis from 28 weeks to pregnancy, at least up to birth, or preferably up to 1 month after birth. The newborn must receive the passive as well as the active immunization, and breastfeeding has got the substantial benefit to both mother and child. So this is something very, very important, and it sets the stage that we do the viral HPV, hepatitis B viral load as well as the hepatitis B antigen. So these are 2024 recommendation, which I will like to emphasize: triple panel testing. So it says if the patient is negative 3 core, the hepatitis B vaccination can be offered in pregnancy itself. So this is something which we are not doing routinely. Of course, we are doing every pregnant woman for hepatitis B surface antigen. No routine change, no change in routine antepartum care, no cesarean section is required if the woman is hepatitis B positive. Breastfeeding is required, and when the viral load is certain amount, beyond certain amount, it is tenofovir eflafinamide 25 milligram or tenofovir disproxil 300 milligram daily. So this is something which drug we have to remember. Hepatitis B, of course, active and passive immunization within 12 hours of the birth. And this is important when the patient comes to us in city or something OPD and they deliver at certain place. So whenever hepatitis B positive, you have to emphasize to the couple, whenever the child will be born, make sure that your child get the 12 hours both active and passive prophylaxis beyond, despite all the 3 hepatitis B vaccination scheduled to the newborn. And hepatitis vaccination is recommended in the pregnancy. So initial management, it is a liver function test, which we note hepatitis B viral load, and HBe antigen is a surrogate marker of the positivity as well as the infectivity. So as a professional, we have to take extra precaution during delivery and the cesarean to protect ourselves also. So whenever sometimes the HPV viral load is not available, HBe antigen positivity is a very good marker that we should start the antiviral drug, and we should make the special protection to protect ourselves as well as the maternal to child correlation. So this is something, this test which is available everywhere. So this is the thing: antiviral therapy indication more than 106 copies per ml, and or the HBe antigen is positive or the aminotransferase level are elevated. Maternal to child transmission, this is important that the HBe antigen positive, if you don't give any antiviral drug and if you don't give immunoprophylaxis, 90% of the newborn will be effective. So this is very, very important that we give antiviral therapy in a right case and we give the whole prophylaxis. So this is what I have already said, and this is the thing that tenofovir and the talbivudin has been drug, and usually we are using tenofovir. A neonatal management, counsel well ahead in antenatal care. This is one thing, and despite all prophylaxis, there can be the 5 to 10% escape rate, and ask again parents to check for the hepatitis B for the newborn in spite of the all vaccination, because there can be the vaccination escape or the failure. So hepatitis C, now we coming to, because HPV infection in pregnancy is not only a unique challenge, it is an opportunity for us. And hepatitis C, these are the friends of hepatitis B. So hepatitis C, no professional body except the American Society of Hepatologists say that we should go routine testing for hepatitis C in pregnancy, but we can consider, because still 71 million people are having chronic hepatitis C infection. So this is important. And the second important thing is the like a viciousness of this hepatitis C, because antibodies against HCV does not produce immunity against the disease the way they produce in other disease. So universal screening, we are not sure, but if the patient, the pregnant woman is having unexplained chronic liver disease, people with sexually transmitted disease, affected partner, drug uses, we should consider hepatitis C, and many of us are doing as it is the hepatitis C screening in the antenatal patient. So incidence is low, but the seriousness can be very high. There can be acute as well as the chronic infection. How we diagnose with the antigen and with the HCV RNA. It has been associated with poor obstetrical outcome, especially GDM, HTB, preterm birth, and the fetal growth restriction. Vertical transmission can occur in the HCV carrier, and the risk of vertical transmission is doubled if the woman is HIV positive also. And the carrier state is associated with long-term complication in offspring like asthma, sleep apnea, and the esophageal disease. So this is very important. And the second thing is HCV woman can have the obstetrical cholestasis. So we have to have a good monitoring, otherwise it can cause unexplained stillbirth. How we manage, it is the same management, but be careful, any invasive procedure that she is the positive, there can be the risk to maternal and child transmission. And if the HCV high viremia and the prolonged rupture of membrane, then we should be very, very careful. So multiple sex partner, drug user, these are the risk factor for HCV, which cause the complication for mother as well as the newborn. Again, the alarm line is there is no vaccine for HCV. There is no safe drug to be used in pregnancy. Ribavirin, I will take 1 or 2 minutes. Ribavirin is the considered teratogenic interferon associated with IUGR. So something which I say that we don't have vaccine, we don't have the good drug. Hepatitis D delta, I will say only 1 point. It is incomplete, but when it is associated with hepatitis B, it can result into more complications. So if the hepatitis B is positive, do hepatitis D testing also, because they are the evil friends. So these are the catch points. And hepatitis E, just 1 point that it is from our own country, Kashmir, Dr. Muhammad, who said that hepatitis E can be very, very fulminant in pregnancy and very, very important life-threatening hepatitis it has. And we have the third trimester more complication. And especially in India, fulminant hepatitis, which may require liver transplantation, and still the treatment is supportive routine antenatal care. We don't have any drug very safe for the hepatitis C, but it can have critical maternal as well as the neonatal complications. So Swachh India is important. We don't have any, China has made the vaccine, but it has not been approved overall. Hepatitis G is again the combination, a friend of HPV, but it does not cause much maternal as well as the neonatal side effect. Herpes, we will have tomorrow session on the herpes, on this varicella zoster. Just 1 point that these patients, varicella as well as the herpes can cause the hepatitis, and they are not hepatotropic, but overall manifestation. So tomorrow we will be dealing with all this CMV, varicella as well as the herpes. So key messages, the global prevalence of viral hepatitis is very high and it is rising. We must have a very good protocol for the screening. Hepatitis A is self-limiting. Hepatitis B, the most important, that don't book like a complication and prevention of maternal to child transmission. And we must be having a little knowledge of the hepatitis C, D, and G, because when they are in combination with hepatitis B or HIV, they can cause a lot of maternal and the critical complication, and that knowledge we must update as an obstetrician and gynecologist. So India is committed to the hepatitis-free India. India has been signatory for the hepatitis-free India. The Indian initiative of immunization for HBV, Swachh Bharat mission, safety of blood product, use of reuse, prevention syringe is the critical. Like this is something what India is committed. So thank you very much. The world gives us answer each day. Just we have to learn to listen, and let's hope for hepatitis-free India. Thank you very much.
Thank you, Sadhna, for the wonderful, explaining all the minute details in such a way, gagar mein sagar bharne ki example diya you have given. So I must say, very, very wonderful, and taking each and every point in so nicely that every woman should be screened. All patients who are positive should be given treatment, and the treatment has to continue throughout pregnancy and should even be continued during the postpartum period for 3 months at least. And the vertical transmission should be not allowed by doing certain precautions that has to be taken care of, and even the newborn has to be taken care of and given the antiviral treatment. So this is very, very nice, and I must thank all of you for the wonderful lecture. Thank you.
Thank you, Dr. Sadhna. Actually, everyone will be scared if we are operating on a retropositive patient. But they have to be equally careful when they are operating on these also. Because, the amount of blood required is very less to get infected with hepatitis B than retrovirus. It is some 0.0004 ml is enough to get infected. So one has to be, universal precautions, yes, is must, but that doesn't happen. But at least when we know, one has to be very careful. Most of us are vaccinated now. At least the healthcare workers, yeah.
There's a transmission rate is more with the hepatitis B virus with a small amount rather than the hepatitis HIV retrovirus.
Yeah,
That is what you have.
I think we have one more talk to go for this session, and we are already delayed to
Excellent
the
talk,
panel.
madam.
Thank you.
Now I request Dr. Sukanta sir to kindly introduce our next speaker, Dr. Satyavani C.
Dr. Satyavani C. She is a fetal medicine specialist and completed her fellowship. She's a DNB trainer and examiner as well. And she had special interest in maternal fetal medicine, of course. And she's going to present our next topic, HIV in pregnancy. Welcome to Dr. Satyavani.
Thank you. Thank you. Am I audible?
Very much.
Yes, ma'am, you're audible, visible. I think all your issues are worked out.
I thank the ICOG team for giving me this opportunity. Special thanks to Sheila Mani ma'am. I would like to present about HIV in pregnancy. HIV in pregnancy is one condition which has undergone remarkable transformation in the past 25 years in modern obstetrics. From being a feared diagnosis, it has become a fully manageable condition. And it is not this situation is not seen only in the high income countries. Even India has done really well in containing the disease and reducing the vertical transmission of HIV. We have managed to reduce it to really nearly 75%. From 35%, the vertical transmission has come down to 11%. This is because of the upscaling of the testing and treating under the NACP, and from prevention, we are now moving towards elimination. But we have a lot of challenges. We are the huge country with 1.3 billion population, and we have the second highest population of HIV living with us. And currently, our MTCT rates are at 11%, and we are having about 2,000 new pediatric infections every year. And the loopholes that we have, which is not allowing us to reduce the MTCT rates further, is the late diagnosis, missed antenatal screening, and adherence gaps, and the breastfeeding dilemmas. The target that we are aiming at is to reduce the MCTC to less than 5% in breastfeeding population, and the case rate of new pediatric HIV due to MTCT should be less than 50 per 1 lakh live births. That is what we want to achieve by 2026, but at least we have to try to do that by 2030. For this, we need to ensure that at least 95% of our women are tested, and if they are positive, they should be on treatment, and at least more than 95 should be virally suppressed to achieve this goal. So elimination is possible, but only if every obstetric encounter is optimized. And in this line, we have the triple elimination policy by the Government of India, which tests for HIV, syphilis, and also hepatitis B. So the basics of management of HIV in pregnancy is to test everybody and to treat everybody irrespective of the CD4 count and the duration of pregnancy, and to reduce the viral load, which will in turn prevent transmission, because undetectable is untransmittable. So the screening guidelines world over is to test the mother as soon as possible, preferably in the first trimester. It has to be a provider initiated testing after adequate pre-test counseling. Of course, the mother has the option of an opt-out approach. Informed consent should be there, and 5 C's of testing, that is consent, confidentiality, counseling, the correct test to be used, and connecting them to immediate care services is important. And retesting is advised if the mother is from a high prevalence area where the ANC is more than 1%. HIV in ANC is more than 1% if she has high-risk behavior and if the partner is HIV positive. So we know HIV type 1 and 2, and there are many groups and subgroups. And in India, HIV 1 subtype C is most common. All people should receive the first test should be a highly sensitive test, which is usually the rapid test in the public health sector and ELISA-based tests. If those are found positive, then it is followed by 2 tests which are highly specific, and all 3 should be positive to consider them as HIV positive. Now, in the public health care facility, the HIV and syphilis has been integrated. So at the first antenatal visit, the mother undergoes screening for HIV and syphilis in a card test, and the result is available within 20 minutes. And if she is found positive, she is immediately referred to ICTC centers for confirmation, and followed by, if positive, then she is linked to ART center for immediate initiation of treatment. And of course, her sexual partners and needle sharing partners are also treated and tested and treated. The post-test counseling is very important. We have to counsel her that the HIV is manageable. The MTCT rates can be as low as 1 to 2%, and there is availability of safe motherhood options. And we have to reinforce the importance of starting ART immediately and continue it lifelong. And also counsel them about safe sex practices so that the chances of reinfection is less. So antenatal care in pregnancy revolves around starting ART, which is needed both for the mother and the fetus, ensure compliance, check viral load and CD4 count at regular intervals, and screen them for ART toxicity and risk of opportunistic infections, and give the necessary vaccination in everybody. And by 34 to 36 weeks, we should make a birth plan based on her risk for vertical transmission. And also the couple should be counseled about the options of breastfeeding and the need for infant follow-up. We know that the mechanism of vertical transmission, it can occur transplacentally in about 10% of the cases, intrapartum in about 15 to 20% of cases, and postpartum through breast milk in about 16% of the cases. If the mother has a recent HIV infection with high viral load and advanced HIV disease, concurrent sexually transmitted diseases, then of course this risk is much more. So if there is no treatment and only with breastfeeding, the risk of transmission is as high as 45%, and in case with the antiretroviral therapy, it is as low as 2%. And with no breastfeeding, it can be reduced further to 1%. So basically, in pregnancy, we have to treat as prevention. That is, undetectable is equal to untransmittable. So the ART therapy leads to suppression of the virus, and that in turn maintains an intact immune system and prevents transmission. And the loading of antiretroviral drugs into the fetus also prevents replication in case some virions have entered transplacentally. So all pregnant and breastfeeding mothers should be started on ART irrespective of the duration of pregnancy, even in the first trimester, it doesn't depend on her CD4 count and the WHO stage. And everyone should receive a triple drug therapy, and it should be lifelong. We know all the various classes of antiretroviral drugs. What is recommended in pregnancy currently is the TLD regime, which consists of tenofovir 300 mg, lamivudine 300 mg, and dolutegavir 50 mg. It comes as a single tablet, and the mother is advised to take this tablet once a day, preferably 2 hours after a meal. Now, the importance of dolutegavir-based regimen is that it brings down the viral load very quickly. Within 2 to 4 weeks, the viral load is reduced to less than 1,000, and it can also be used for co-infection with hepatitis B and also TB, and also in women exposed to nevirapine. There is no problem of resistance, and it is effective even against HIV too. Now, few side effects that we should look out for are tenofovir causing nephrotoxicity, lamivudine causing a skin rash, and dolutegravir can cause hepatotoxicity and, importantly, impaired glucose tolerance. So we have to keep these women under follow-up with a renal function test, liver function test, and blood sugars and a complete blood count. So once the diagnosis is made, the person should be initiated on ART, preferably on the same day, and they have to undergo clinical monitoring of the staging at every visit, and they have to be monitored for symptoms of tuberculosis at every visit, and they have to be screened for the adverse effects every 6 months. And depending on the stage of the disease, if the mother is in stage 1 and 2, we do not expect to see many pregnancy complications. But if she is in stage 3 and 4, the mother is more prone for infections of like UTI, tuberculosis, candidiasis, and the baby is also prone for preterm delivery, FGR, and stillbirths. If their CD4 count is less than 350, then they are prone for opportunistic infections, and hence they need chlorotrimmoxazole prophylaxis. Once the treatment has been started, NACO recommends testing for the viral load at 6 months, and in pregnancy, it has to be tested at 22 to 36 weeks to decide about the mode of delivery. But British and SMF guidelines do recommend testing for the viral load after 2 to 4 weeks of initiation of therapy and once every trimester. So if the viral load is less than 1000 copies per ml, it means that the ART is working and we have to just continue the current regime. If it is more than 1000, it means either the mother is not compliant or the ART is not working, and hence the situation has to be reassessed. And if it remains undetectable, it does not mean that the HIV has disappeared, but it is still present, and so she has to continue the treatment. And the risk categorization depends purely on the viral load. So few drug interactions that we should be aware of is metformin. We have to use not more than 2 times when the person is on dolutegravir. And if she is on anticonvulsants and antitubercular drugs, then the dose of dolutegravir should be increased to twice a day. And since it can be affected by food and other substances, it has to be taken 2 hours after a meal. Coming to mode of delivery, the key determinant is the viral load at 36 weeks. If the viral load is less than 1000 copies, then there is no additional benefit of doing a cesarean section, so she can be offered a vaginal delivery. But if the viral load is more than 1000 copies, then an elective section is done after 38 weeks before the onset of labor or rupture of membranes. If the mother is on ART but the viral load is not available, then we have to treat her as high risk and proceed with the cesarean section. If she presents late in labor, yes, late in pregnancy, of course, she will need a cesarean section. Sometimes, even if the viral load is high, but she presents in advanced labor for more than 6 hours of rupture of membranes, then the benefit of cesarean is lost. So when we are delivering these women, definitely universal precautions, avoiding repeated vaginal infections, artificial rupture of membranes, invasive fetal monitoring, routine episiotomy, and instrumental delivery should be avoided. If needed, a forceps is better than a ventouse delivery. The suctioning also should not be very vigorous. And in case the couple have opted for breastfeeding, then it has to be initiated. And delayed cord clamping can be practiced as per guidelines. Now, if we are doing a cesarean section, we have to minimize the blood loss and the blood spillage. So we have to follow correct facial dissection, can use electrocautery, and it is better to leave the membranes intact till the head is delivered through the surgical incision. And of course, we have to be careful with the sharps and ensure that they are properly handled and discarded. If the mother presents in active labor, then she has to be initiated on TLD regime. And if the confirmatory tests negative, then it has to be the ART has to be stopped. When you look at the risk categorization of the fetus, if the mother of the newborn, if the mother has received retroviral therapy and the viral load is less than 1000, then it is a low risk fetus. But anything else, that is, if the mother has received less than 6 weeks of therapy, or if the viral load is not tested, or if it is more than 1000, it is a high risk newborn. So if it's a low risk newborn, baby will need prophylaxis with either nevirapine or zidovudine for 6 weeks. But if it is a high-risk baby, it will need nevirapine and zidovudine both for a period of 12 weeks. So breastfeeding, if the viral load is adequately suppressed, it is not a contraindication. They can continue. But if their patient is not on ART and the viral load is high, then better to avoid. Even if replacement feed is allowed, it has to be done only if the AFAS criteria are met, because in our resource-poor country, instead of losing the baby to HIV, we may lose it for diarrheal and respiratory diseases. So unless it is acceptable and sustainable, we should not be starting them on therapy. Now, a small word about post-exposure prophylaxis, because as healthcare workers, we are worried about it. The exposure, needle stick exposure is as low as 0.3%. As ma'am was saying, the HBV and HCV are more, they can cause it more commonly than HIV. And the drug that is used again is the same TLD, preferably to be started within 2 hours and not after 72 hours. And it has to be continued for a period of 28 days. And the tests have to be repeated at 6 weeks, 12 weeks, and 24 months. Now, India has come a long way in the elimination, but still our MTCT rates are at 11% and ART coverage rates is at 89%. So we have lots to be done. So elimination is no longer it is not limited by science or resources. It is only limited by missed opportunities. And so it is it's not a future goal, but each and every one of us should feel it is our present responsibility. So we should test early, treat promptly, and follow relentlessly to try and eliminate this disease. Thank you.
Very, very good. Doctor, you spoke very beautifully, and it is very, very important for everybody to understand the competition which can occur, because you never know which case is going to come. So it's very, very important. So it's very, very important that we, all of us, we look into the test for the patient until the report is there, because this test is very simple and it is available with all of us. So it's very, very important for all of us to be understand about this case. And more importantly, that if you get injured by mistake, the risk of hepatitis is much higher. So you should all know what is a post-exposure prophylaxis for yourself, your staff, and your all technical staff. And I would like to thank the ICOG chair, Dr. Sheila Mane, Dr. Sadhna, and all the Secretary General and all dear friends who are present here for inviting me as faculty for this program, because as all of you know that I am really, really very emotionally attached to HIV. So thank you very much for inviting me, and very, very good. If anything else, any kind of queries in the chat, I can answer those chat to anyone. Thank you so much.
I think we are running late, so we will move ahead. Yeah.
Thank you once
So
again.
for everybody who's asking for the
Madam,
poster, link,
it is
it will be posted
pointed out that
after the
elimination is
panel.
not a
The
problem.
panel is still pending.
Screening. It is only by chance of missing to get the screening only. All the supportive nature is also the very important thing, right? Thank you all for making me the faculty in this team.
So thank you so much all the chairpersons for their valuable inputs, and thank you so much all the speakers for for sharing knowledge with us.
Thank
Now
you,
we
ma'am.
quickly move on to our next session, and I request Dr. Mosmi to start the next session. It is a panel discussion on fever in pregnancy. So Dr. Mosmi.
Yes. Moving on to the next session. So it is on panel discussion, fever in pregnancy, case-based discussion. I welcome our moderators, Dr. Aradhana Singh and Dr. Sanjita Dubey. Can I have the CV of the moderators, please?
So nice to see 600 people still listening. Till then.
Yes, madam.
Okay.
And they want session of 30 minutes, not 15 minutes.
Yeah.
That is true.
So Dr. She is the president of Noida Amsang Gandhi Society and additional director of Fortis Hospital Noida. I welcome you, ma'am. And Dr. Sita Dubey. Next slide. Dr. Sita Dubey. She is a senior consultant of Apollo Hospital Noida and director in Evidence Healthcare Noida. So it is this session is all yours, and we have a lovely panelists. Dr. Monica Gupta, Dr. Santa Gupta, Dr. Prachi Sharma, Dr. Deepa Gupta, Dr. Sonia Mandapa, Dr. Apala Priyadarshini, and expert Dr. Sukumar Barik. So the floor is all yours, madam.
Can I share the slides?
Dr.
Yes,
Vidya
ma'am.
Sobi is also, Dr.
And
Vidya
Dr.
Sobi
Vidya
and Dr.
Sobi is also
Sukumar
there.
Barik, expert, yes.
Dr. Vidya Thobi is currently the Vice President.
is
We welcome you, Dr. Vidya.
Thank you, Dr. Sheila. Thank you very much. So, first of all, very good evening, everyone. And thank you, Sheila Mane ma'am and Sadhna ma'am and Dr. Prateek for giving us this opportunity to discuss this a very important panel on the febrile illnesses during pregnancy. So, as Dr. Sanchita, you have to keep on changing.
Yeah, all right.
Yeah.
Just a second.
Yeah, so I, along with Dr. Sanchita, will be moderating this panel, and where experts have already been, introduced, Dr. Vidya and Dr. Sukumar. So I welcome all the experts and panelists here. So we'll be discussing the syndromic approach towards the fever in pregnancy. We'll discuss the approach and care pathways and what we can do to the medical and obstetric decision making. We'll be asking the short questions and brief answers we expect from all the experts so that we can cover all the, all the cases. Next, please.
Actually, we have discussed all these in detail, so we will be just, asking our panelist a clinical approach and how we should go about all these cases.
So, to start with the context setting, so I'll be asking Sanchita, you have to keep on changing because the
Yeah,
name is
yeah,
coming.
I'm doing it, yes.
So, Dr. Monica, is she here? Does a raised temperature by itself have a significance in the pregnancy?
Yes,
The panelist,
definitely.
yeah.
Good evening,
Yeah.
everyone. Thank you
Yeah.
for making me part of this program. And as we all know, pregnancy itself is a hyperthermic state. And because of the progesterone, 0.2 to 0.5 degrees centigrade is high. But if it is higher, it can lead to many complications in the fetus as well as mother. There can increase chances of congenital anomalies. Neural tube defects are more common. Other congenital anomalies can also occur. Even there's a heat-induced disruption in the embryonic cells, and that can lead to the developmental defect. It can trigger to the preterm labor, can lead to PROM, decrease in the amount of the liquor, and many times there can be a sudden death of the fetus can also occur. Many times there can be a fetal tachycardia or false fetal distress we can diagnose. Even the maternal dehydration can be there. There can be increased metabolic demand from the mother, and that can worsen her conditions. And there are increased chances of miscarriage, fetal acidosis, increased chances of fetal obstetric intervention can be there. And we have to, there's an urgent need for evaluation. What is the cause for the fever in this
Yes.
patient?
So very well
For
explained by Dr. Monica that there are early pregnancy risks and there are late pregnancy problems are also there. There are interpartum complications, early pregnancy failure is there, and the fetal effects of tachycardia is there, and the maternal, of course, metabolic stress and the urgent evaluation of the infection is needed. So next slide. So why is the fever is clinically challenging for the obstetrician per se, Dr. Samta?
Yeah, good evening. First of all, thanks for making me a part of this. So, fever in pregnancy is a clinically challenging situation, as we all know that there are physiological alterations in the pregnancy, which can mask the common symptoms of the fever. So, there can be delay in the diagnosis, and the diagnosis can be difficult. Apart from it, a pregnant female with febrile illness are more likely to develop critical outcomes, and the treatment options are also limited when we are treating the pregnant female. Along with it, there are fetal complications. We all know that some infections can lead to fetal complications and neurological development, and all can be, and there is increased risk of both maternal mortality, morbidity, as well as perinatal morbidity and mortality.
Yeah, so very well explained by Dr. Samta. And apart from all these
As an
things,
obstetrician, it is.
yeah.
Your
Yeah, you can
voice is
continue.
breaking, Samta.
Yeah.
Okay. So
It's
is it
little
clear
breaking.
now?
Yeah, yeah.
Yeah.
So
very
shall I
well
repeat?
explained by you. And apart from all these problems, there is actually the fever is not the core area, the core competence area of the obstetrician. But yes, we have to know everything. Varied etiologies are there, diagnostic dilemmas are there, and prompt action is needed. That's why it can be very, very challenging for the obstetrician to manage fever. So now, what are the most common etiologies for fever that you see in your obstetric practice, Dr. Pranjal?
Etiologies can be grouped under infectious as well as non-infectious. There are some infections which are particularly related to the pregnancy, obstetric infections, like more proneness for the urinary tract infection or chorioamnionitis, or for that sake, puerperal sepsis or septic abortion, etc. General infections like that of respiratory tract infection, then again gastrointestinal and other skin infections are there. Then viral infection, as we discussed in detail just a few moments before about the viral infection. There is a range of especially COVID-19, dengue, etc. Then parasitic infections like malarial infection and toxo infections, and some particular infection which are detrimental for pregnancy like listeriosis, brucellosis, and HIV infection.
Yeah, so
So this
apart
is all.
from the rarer ones, of course,
This
very
is a list
nice.
of
Yeah.
infective, but there are non-infectious conditions also. One must
Okay.
remember
So
that
we are discussing
physiologically
about the common infections.
common
So like
infection.
common things are the
Yes,
UTI,
UTI,
respiratory tract
respiratory.
infections, the vector-borne disease, the tuberculosis, and GI infections.
In
So
first
very well
trimester,
enumerated.
in
Yeah.
first trimester, one should be concerned about the physiological change where the temperature of the body
Yes.
rises by 1. So it should be taken.
Yes.
Physiological change should not be confused with the pathological one.
Very valid point. Next, please.
So, yes, very correctly said that we should not always consider infection as a cause of fever. There are a lot of non-infectious causes for infection. So that also should be kept in mind before screening. But probably in this, we have covered mainly the infectious causes.
The common etiologies.
Common
Next.
causes, yeah. So after discussing the etiology, let us discuss about the initial approach. So Dr. Deepa, I would just like to know what are the important aspects of history taking that help you or help us in narrowing down the diagnosis?
Yes, Dr. Sanchita, the fever really needs a rapid assessment, and the key aspects of the history will be like what are the symptoms, how the onset and the pattern of the fever, is she has any respiratory symptoms, any urinary or a GI symptoms that will, and if she has any skin problem, any development of the rash, which can exclude the chicken varicella or the viral illnesses, then we need to a detailed obstetric history, like what is the gestational age, any rupture of the membranes is there, any vaginal offensive discharge is there, or any risk factor associated like diabetes, anemia, or immunosuppression is there, or any history of abdominal pain is also very important. Then a very important thing is the travel history. Any exposure as has been traveled to an endemic area of a malaria or a dengue, or some like sick contexts like listeria or toxo can be there. And sometimes the seasonal clues also, at what time of the year she's developed the fever, that is also becomes very important and helps us to make a diagnosis on that.
Very correctly said, Dr. Deepa.
Contact
So
history is also
detailed
important.
Pardon?
Contact history with any of
Contact
the
history,
physical
yes.
appendages.
So
They came into the contact with
very
that. We
important
have
to
to ask
take
them.
these points in history, then the symptoms, and of course the clinical examination. All right. So moving on to the next, this thing is, as we discussed that, does the time of the year influence your diagnosis? Yes, we have discussed. So Dr. Sonia, can you just elaborate?
Yeah, thanks for the question, ma'am. It's a big yes, because the time of the year, the seasonality, what we say, it influences the differential diagnosis when we actually speak about fever in pregnancy. But it may complement the diagnosis, but it will not replace the judgment clinically. Likewise, if it is winter, November and December and January, when it is very cold weather, we expect a lot of respiratory tract infections, influenza, and viral infections also. When it comes to summer, if it is March, April, and May, we know that the dehydration is very common. They are more used to for a cold drink. There is sore throat, there's fever, upper respiratory infection. And adding on to that, there's more gastrointestinal symptoms then. Typhoids are very common then. Acute gastroenteritis is very common. Then in monsoon or post-monsoon, we should always think about There is breeding areas of mosquitoes, which is very, very common, and they're likely to develop malaria, dengue, chikungunya, and leptospirosis. And along with that, the history actually the other panelist has added on. I think it's a blend when we have to diagnose, when we know about the seasonal variations.
And of course, the hepatitis, which
Epidemic
Dr. Sadhana has just
situation, so-
discussed, that's also a very important part.
COVID and then flu.
All right. So then, how it is important from the obstetric point of view on the history which we ask to the patient, Dr. Alpana.
Thank you, ma'am, for the question, and thank you, Sadhana, ma'am, for the wonderful opportunity. Now, if we look at the patient from the obstetrician's point of view, it is extremely important to look at the gestational age, because we know that the effects of the causes of the illnesses are trimester-wise. For example, if we have rubella in the first trimester, it will cause teratogenicity. However, if they contract varicella, the more later age of pregnancy, it will be the more risk of neonatal varicella syndrome. So that is important. Then other uterine symptoms which point towards chorioamnitis, like prolonged leakage or foul-smelling vaginal discharge or pain, contractions. Bleeding is important both in the late pregnancy as well as in the early pregnancy, because we have to take a history of uterine instrumentation also, because many a times patients will come with amenorrhea. They're actually a case of septic abortion, but they will never give any history of any instrumentation. Then to look at the red flag signs, we have to look for decreased fetal movements, and as immunization history is extremely important regarding varicella, COVID-19 vaccination, influenza status, etc.
And of course, sometimes the catheterization also leads to infection. That was also discussed in the UTI talk. So mainly we are having just a quick revision of everything what we have discussed. So on examination, what are the features which points towards the site-specific etiology, Dr. Monica?
Site we have it is very important to know the features of the site specific etiology, because it will help us in diagnosing the things and targeting what investigations are really needed to the patient. If there is a suprapubic pain, we can think of the UTI. If it is a costovertebral pain, we can think of the pyelonephritis, though it is not 100% sure, but it can give some idea about it. If there is a tenderness of the uterus, we can think of the chorioamnionitis, or when it is with the foul smelling discharge. If there's a respiratory symptoms and we have got some chest pain, or then it can be a lung infection like pneumonia, or there can be skin rashes are there, so we can go for the fever with rash diagnosis. And we can many a times there's a systemic illnesses also, but when we get the some localizing feature, it will really going to help us much.
Thank you very much, ma'am, for the elaborative this thing. So, of course, we need to just keep thinking about each and every system and keep ruling out what specific should be the cause of the fever so that we can act accordingly. It may be respiratory, urinary, gastrointestinal, very rarely meningitis, hepatitis. So all these things you have to keep in mind. Of course, chills, we will be discussing it in the later cases. So the next question would be for Dr. Samta. How does the pattern of fever, which is significant in concluding to the diagnosis?
Yeah, am I audible now?
Yes, yes, Dr. Samta.
Yeah. So the pattern of the fever is important because it can narrow down our differential diagnosis. So if it is a intermittent tertian cotton pattern of fever, that is every 48 hours or 72 hours, then we can narrow down it to malaria or pyelonephritis, along with if it is with chills. If it's a stepladder pattern or continuous fever, then again a sepsis or a typhoid can be one of the differential diagnoses. Then remittent fever, which is coming and is not completely going off, can be common in very important viral infections and the bacterial infections. Then evening rise of temperature, we all are familiar, can be with the tuberculosis. Then hectic pattern can point out towards the iliac vein thrombosis and purpural sepsis. So these are the different patterns by which we can narrow down the differential diagnosis and accordingly manage the patient.
So during history taking, knowing the pattern of the fever is also very helpful in concluding to the diagnosis. So, Dr. Pranjal, can you just elaborate what all lab investigations are needed in women who presents with fever in pregnancy?
Yes, they should be it is mandatory to do all the lab investigations, especially. But to start with, we'll go with the CBC and urine routine basic investigation, LFT, RFT, routine. If the urine is not showing anything specific, then culture of the urine. If you are suspecting the urinary tract infection, if the patient or they are living in the endemic area or coming history of travel to endemic area, then malaria, dengue, these investigation. History of travel is there, then COVID, then Zika, and in some cases with proper shielding, chest X-ray, etc. USG of course is needed from time to time. That should be done. Investigations are very mandatory to not only to diagnose but to assess the severity of the disease and for prognostic purposes, also for medical legal purposes.
So one thing which we are very hesitant about the chest X-ray, in case there are respiratory symptoms and you need a chest X-ray, can be done with the abdominal shield, of course. And chest X-ray has a very minimal radiation exposure, so we should not hesitate if required. And for investigations, I mean, it is good to act quick and do investigations before things get complicated. So we need to keep a
Yes.
low threshold for the investigations in pregnancy. Now, Dr. Deepa, can you just elaborate how and when we need to take an opinion of a physician when a patient of fever comes to us in pregnancy?
Not every fever in pregnancy is a red alert. That we need to understand. And if there is a mild cases like a viral fever or a simple UTI, then it can be managed by an obstetrician. Or if the patient is stable, then also an obstetrician can manage. But if it is associated with it's very high grade fever, or the fever has been more than 24 hours, and the patient is hemodynamically unstable, severe illness, you see the signs of sepsis, or you have got done a good workup and still the diagnosis is not clear and the patient is not responding, then in that case we really need to refer to the physician, and the early referral is the key. That is very important. So we need to have a team approach, including infectious disease specialist or intensivist or a physician in high risk cases.
So yes, definitely. Every fever comes to us first. We should do a preliminary workup, and 80% of cases are usually the seasonal flu and things, they settle. But yes, if it is getting prolonged and it is too high, then we should not hesitating in referring to the physician, definitely. Dr. Radha.
Yeah. So now coming to the fever with rash, and very important point here, we have already discussed that early referral is very, very important, to avoid the litigation in today's era. So fever with rash, this is a case, a pregnant woman presents to clinic at 8 weeks of gestation. She has a single live pregnancy on ultrasound done last week. On examination, she has a temperature of 100°F and a rash. She's otherwise well with the normal general systemic examination. Next. So, what are the general typical patterns of rash that are seen with common febrile illnesses during pregnancy? So, Dr. Sonia, can you explain the general rashes which you come across in your practice?
So now this case is first trimester, then recorded temperature of 100. I'm worried because we already spoke about organogenesis, and this is the time I should not be neglecting the rash. And if it is the rash, then I have to categorize this. The distribution of the rash is important, and actually the presentation of the rash is very important. Now we all know if there is a maculopapillary rash, which is starting from the face and then moving towards the trunk, and this is associated with kind of a lymph node involvement, especially the occipital, it is more towards rubella infection. If the patient has got fever with rash, but then myalgia and diagnosed thrombocytopenia, and it is definitely dengue. If that is the case, then the rash is usually what we call it as white island patch, and that is very specific for dengue. That anyway is supported by the other diagnosis, maybe the blood diagnosis. If the case is a vesicular rash, then we say it is just like a dewdrop on a rose petal. It's a very, very classy rash, and that actually is macular, and then it becomes papule, then it becomes vesicle, and that becomes a crust. And it usually is in the trunk. So that's more favoring inspection, and that is vesicular rash.
So the previous slide once more, Dr. Sanchita, where
if it is
rash is reduced. Yeah, this
yes,
one.
if it is non-blanching spot, then also we can think of dengue again. But if it is a slab cheek, that is a lacy check appearance, it is very, very typical of an erythematous rash, and we should not miss on COVID and also paravirus.
Yeah.
If the patient is complaining of genital pain and there is some labial rashes also, it is more favoring a herpes simplex.
So here
very
we have
important
already
is the distribution of the rash and the type how it is presenting at the time when we
Yes, so
examine
for the sake of students,
Usually,
Dr. Sonia,
herpes will not come with fever, actually.
Yes.
Dr. Sonia, so this is the picture for the students who are attending here. The chickenpox rashes are shown here. The rubella rashes are shown,
Which
which
is
are
on the
from
trunk.
base to trunk. In chickenpox, they start with the trunk and the morphology, the ulcers, the blisters, the papule are seen, and then the
And then
crusting
it
later on
regress.
as they mature. And herpes simplex, the typical labial, genital, vesicular, very, very painful
Very, very
rashes.
painful rash.
Next, please. So the fever with rash in the first trimester, it's very important, as you said. And then main categories are pregnancy rashes, non-specific viral fever rashes, and specific viral rashes. So viral rashes, if they are widespread, transient macules like the pink, throughout the scene uniformly pink. And pregnancy rashes, they are at the non-specific sites. Itching is there, and papulars and flat, this thing is there. And usually liver functions are deranged many times in cases of IHCP. Next, please. So fever with rash we have already discussed. So what are the common rashes are seen without a fever in pregnancy, Dr. Apala?
So thank you, ma'am. Ma'am, there are basically 4 dermatoses which are unique to pregnancy. One is PU, PPP or pruritic urticarial papules and plaques of pregnancy. The other is pemphigoid gestationis, atopic eruptions of pregnancy, and intrahepatic cholestasis of pregnancy. What is common features with all of them is pruritus. Gross appearance is similar with erythematous red macular or papular patches. What is the difference is that adverse fetal outcomes are associated with only 2 of them, that is pemphigoid gestationis, which causes preterm FGR and transient neonatal lesions, and also IHCP, which we all know has perinatal morbidity as well as mortality. Certain differences are there in the distribution, like pemphigoid has umbilical involvement also, and PU-PPP has umbilical sparing, and certain differences in the flexure and extensor surfaces. Otherwise, all these rashes are there without fever in pregnancy.
Yeah. So this PUPP can be sometimes, very, very, very extensive and very disturbing for the patients, though it is not that, the relevance with the fetal outcome, adverse fetal outcome, but can be very disturbing for the patient. She can come again and again to you. So you should know how to differentiate from the fever with rash, with the infections and without infections just due to pregnancy. So what patterns could indicate the varicella infection? I think we have discussed about the rashes.
Yes, the rashes.
It is typical.
I
The
request the
centripetal.
moderators to kindly conclude fast.
Yes.
Thank
So
you.
the chickenpox rashes are there. Next, we have discussed. Next, Sanchita. Yeah, we are concluding, ma'am. So varicella in pregnancy, if the infection is very dangerous, the treatment part anybody can explain. Next, Sanchita. Dr. Sanchita. Yeah. So Asivir, any Dr. Pranjal about the use of Asivir safety?
Yeah, if there are acute infection or just resurfaced, we should not be hesitant to give the basic dose if the patient's weight is less than 60, then 400 milligram 3 times a day for 7 to 10 days, or oral regimen can be started with 800 mg for 7 to 10 days,
Yes.
five times,
So
and
it
in
is safe.
severe. This is for the acute infection, and when we want to suppress the therapy, especially near term, when you are planning for her delivery, at that time also suppressive therapy can be induced at 36 weeks
So
of
safety
gestation.
you can explain to patient. It is category B,
Yes,
safe.
category B.
Theoretical risk are there and benefit
Yeah.
should be overweight. Next, please.
All right. So again,
So would you advise termination, Dr. Deepa?
No. The early trimester exposure is there, but the risk of there is very little risk of the varicella syndrome, but that is hardly 1 to 2%. So I will not recommend termination of
So
pregnancy in
this
this.
is the message to be given, that the termination is not advisable. The risk is just 1 to 2%, very low risk. The fetus can be followed in the ultrasounds, upcoming ultrasounds, and majority of the pregnancy is the normal outcome. Fever with chill, Sanchita.
Ma'am, can we go ahead with it, or shall
Yeah,
we just conclude?
because
Fever with
we
chills,
have still
I think, ma'am, we
malaria
will
and
quickly
dengue
rush
has.
through the
I think
cases. Ma'am, just 2 minutes, we'll rush through the cases.
Okay,
Fever
so
with
we'll
chills,
just
Sanchita, we have already discussed in UTI this
ठीक
thing. You
है.
can,
So fever with
yeah.
chills, most common etiologies for this would be differential diagnosis we have discussed. I'll just rush through it. So we know pyelonephritis, chorioamnionitis, malaria, dengue, we have discussed everything. We know what all primary investigations we need to do. We have discussed this. And yes, high fever, we need to admit the patient, give her IV antibiotics, and of course, a multidisciplinary approach is important
I
in
think you
this.
can come to labor thing, because the UTI has been discussed.
Yes, yes.
And
So,
even the respiratory infection
so
has been discussed.
dengue, malaria, we have discussed in detail. So now the late pregnancy, how should we proceed with this? This is also done differential diagnosis. COVID छोड़ देते हैं.
So Dr.
Evaluate
Vidya or
the
Dr. Sukumar, any comments in the fever in late pregnancy, how we should go about the expert comments?
I think the beautifully described the differentiation is that whether it is just mild flu, which is the commonest one, versus a very serious one which needs really stabilization, really care of the multidisciplinary team. That is the basic thing we have to think about. Because the large majority, as ma'am has already mentioned, that 80% of the time it will be just simple flu. But on the other side, about 20% of the side, it can be a serious illness. And that serious illness is really has got a poor outcome, particularly the late pregnancy. So you have to be careful to stabilize it, then detect the specific cause, and then go for the specific treatment. I think that should be the approach.
Thank
So,
you.
Yeah, I just have a
Dr. Vidya,
comment here.
yeah.
Yeah. So you ask about the fever in late pregnancy, and we should know about the various other causes apart from the infective causes or whatever the causes, viral causes, bacterial, whatever. But we are fearful about the fetus and the chorioamnionitis, then UTI. These are the very common causes.
So basically, when we talk about fever in late pregnancy, our decision should be based on the
Yes,
obstetric cause. Fever
obstetric
should not
causes.
be the reason for
Yeah,
terminating the pregnancy or
terminating the
taking any
pregnancy.
action.
That is what I
Any
want to.
CTG
Yeah.
changes, any specifically CTG changes anybody wants to explain? With the fever, any misleading factors with the
There can be
CTG?
tachycardia, which can be because of the
Misleading.
temperature.
Tachycardia can be misleading. Yes.
That can be misleading. There can be decrease in the variability. So we can falsely diagnose the fetal distress,
Yes.
though it is not there. And
Yes,
many
so
times
it
we have
can
missed.
come, yeah. So it can mask the acidosis, it can come normal, or even if it is coming abnormal, it cannot be that severe. So we have to be closely observing the fetus and monitoring it very well, closely. So
So
ultrasound is
fetal
not
CTG
again has
monitoring
to be
should
an
be,
obstetric indication only. If there's
yes.
decreased fetal movements or oligohydramnios, IUGR, are you expecting any
And
congenital abnormality?
ultrasound also is not indicated in every case, only for obstetric cause. We should be.
Many times we can diagnose the pleural effusion in the ultrasound also, if we are
Yes,
not going
yes.
for the X-rays.
X-ray, yes.
Just talk about the indication for cesarean section in fever, right? So all
Yes.
patient, that is very important.
So, what is
Yes.
the important, like now we talk about the delivery and labor with fever cases. So, yes, you need to stabilize the patient. You need to know what are the CTG changes which can be misleading. So, you have to be careful. You don't have to conclude anything. You can give time to the patient to get stabilized. We are not in a hurry to deliver. And of course, cesarean section, as we just discussed, is not an indication. Fever is not an indication for cesarean section delivery, so it should be reserved only for obstetric cause. But yes, if there is a signs of infection like
Sepsis.
chorioamnionitis and all, we may have to take a decision for quick delivery.
Yeah. So it was an excellent panel by Dr. Sanchita Narana, and I think all the panelists have put their heart, mind, and everything in the panel. I congratulate for this very important panel. I think much more time should have been given for this panel,
True,
and
ma'am.
people are very eager to put their comments for the post test. But this is very important topic, that is fever in pregnancy,
I think,
and yeah.
Sadhana, we can keep talking, we can discuss, but we should
Yeah.
start the test.
Yeah, you can
I think
start the
our
test because
discussion can go on.
people are
Yes.
very
So you
very
can
eager.
conclude, Dr. Sanchita.
Just few reinforced
Comments.
points that
Yeah,
fever
yeah.
in pregnancy is a broad differential and potential for maternal and fetal risk. Requires systemic evaluation, history examination, targeted investigations. Early recognition is very, very crucial, and management should be based on maternal treatment and fetal safety. Multidisciplinary approach that is what is important and which improves the outcome. So assess early, act promptly, monitor closely. Fever in pregnancy should never ignore and always evaluate holistically. Thank you very much.
Yes.
Thank you very much,
Yes.
everyone.
Yeah.
Thank you.
Thank
Thank you,
you.
all the
Thank you very
experts and
much.
Thank you, ma'am.
panelists.
Thank you, Sheila, ma'am.
Thank
Dr.
you. Thank
Pratik
you. It
sir,
was an
Sadhana ma'am,
excellent
for the
panel.
It
opportunity.
was a great panel.
Absolutely, ma'am.
See, the
History
backend
taking
team
symptoms.
start the link.
Yeah.
Link,
They can
link.
put
Okay.
the
Yes,
link.
ma'am.
Let them
Link has
start.
Ma'am,
been
link share
posted in
कर
the
दे
chat
please
box
सबके
now.
लिए.
I think
Link share
This is
kara.
very important. Nilima, share
Link
the
has
link,
been
Link
please.
is there in the chat box
Yes.
already. If
for
people can
delegates,
just take a moment to look at the chat box, they will see the link there.
Yes, they
And
have
we'll
to.
have the QR
Yeah.
code on the screen as well. Thank you very much, Dr. Radhna Singh and Dr. Sanchita Dubey,
Thank you.
all the
Thank you,
learned
Dr. Pratik.
panelists for an excellent revision. It was a fabulous panel. Shame that we couldn't give you enough time
Yeah,
because the
I
program was
agree.
running
I
late.
It's
agree
a
with
lot of
Dr.
Maybe we
It's a
will
Pratik.
do
very
it
wide
again
topic,
at a
actually.
later point in
True.
time.
Very
Thank you, Dr.
practical point.
Aradhana and Dr. Sanchita, for making
Very
a
They had
nice
worked very
panel.
hard on
Thank
the
you,
panel and
Dr.
prepared a
Radha
lot of
and
nice
Dr.
slides. Thank you
Sanchita.
very much for all your hard
Thank you,
work.
sir. Thank you,
Thank
sir.
you, all the
I
panelists,
agree.
Dr.
I
Vidya
agree
and
with
Dr.
Dr.
Sukumar.
Pratik.
Thank you, our
Aradhana and
experts.
Thank you
Thank you,
very
Sanchita.
much.
ma'am.
Thank you,
Thank you.
Sheila
It
thank you,
was
ma'am.
beautiful.
Aradhana.
Thank you,
Thank
Sadhana
Rocking,
ma'am.
rocking.
Wonderful
All the
panel.
speakers, have done an excellent job. You can see 540, 60 people still logged in. That itself
सगळ्यांना
tells you that
सर्टिफिकेट पाहिजे मॅडम.
No, ते सर्टिफिकेट साठी ते पॅनल पण त्यांचं
I think
सगळं.
all the delegates should scan this QR code, and after some time, the questions will be displayed on the uh, screen, and you will get 15 minutes for that to answer, and then we will share the answers also. So please scan this QR code. You don't have to write the answers in chat box. That is very important. You should not be writing answers in chat box.
Yes.
there are 20 MCQs. That's all. Very
Yeah, there
simple.
are 20 MCQs. Yeah, MCQs.
15 मिनट.
So, congratulations to all faculties, all participants, and the leadership of Dr. Sheila Mane, which whom we have something lifelong relationship with Dr. Sheila Mane, and very very close and instant rapport. And Pratik, who is very a quiet but very strict person, so that makes a very good team and the complementary team, we can say. So thank you for all the chairperson, Dr. Arup Maji, Richa, Dr. Kiran Chandna, Aruna, Shashi Bala.
He's requesting us to keep silence because I
Achha,
think.
okay, okay.
They can reduce their volume, that's fine. Please continue.
Because we are already late, na, around so Dr. S.N. Tripathi just say, नीलिमा आपने उनको अनम्यूट कर दिया. डॉक्टर सिंधु नंदिनी त्रिपाठी के नाम से. मैडम अभी आप हैं तो आपसे like if you want to say something, Dr. Sindhu Nandini, because she was very she is there and she has listened everything, but she could not talk and she could not give her comment.
Ma'am,
So
she can unmute herself, ma'am.
I don't know, there must be some इशू।
नहीं, वो नहीं कर पा रही है chat
हाँ,
box
नहीं
से।
कर पा
मैंने
रहे।
मैंने रिक्वेस्ट भी भेजा है मैम उनको कि अनम्यूट करे।
अच्छा अच्छा, हम लोग यहाँ से नहीं ask to unmute. So, because it is great, it is really motivating to have teachers like Dr. S.N. Tripathi, Madam Dr. Manju Verma, and Dr. S.P. Jaswar, Pratibha, of course, Pratibha and Mauchmi for all the coordination, and our Dr. Anju Soni, who herself has been the chairperson of HIV committee, Dr. Sukanto Mishra, Dr. Somini, and a wonderful panel by our young brigade, that is Aradhna and Sanchita. Dr. Vidya Thobi, Dr. Sukumar Barik with their expert comment, and all the panelists were young and they contributed in a very decisive way. That was the beauty of panel, that they were very clear, and that is the thing that whenever the patient comes with the fever, the whole family is very much concerning, and we have to sort out which is the innocuous and which is the omnious, and a wonderful discussion. All the speakers, Dr. Aruna, Dr. Shruti Uma, Dr. Maushmi Josna, Dr. J.B. Sharma, who joined from USA, myself, Satyavani Girija, and who have done all the justice, and this infection in pregnancy is something very challenging for our country, because in our country we have all many byproducts of the infection. In resistant anemia is one of the things, low having the fetal growth restriction. So we have a lot of bifurcation from the result of infection and infestation, and that's why we as a Indian obstetrician gynecologist must be very very clear, and very have a sharp clinical acumenship in differentiating between what is the cause of disease and how we should go. And the vaccination, we have to understand, and we have to optimize the vaccination in pregnancy as well as the preconception and the postpartum period. So 2 days are there. Tomorrow we will, all the benefit of audience and the participant, tomorrow we will have the full session on the maternal sepsis, that is the obstetrical cause of infection. And on the Thursday, we will have the full session on the fetal infection in pregnancy. In both of the situation, there are a lot of dilemma. We have a expert pan-India faculty, and we look forward to your gracious presence as well as the certification in the big number.
I just want to say something.
Yes.
All of you have joined. Next time when you get the information, try to spread the message to your friends. And once you start collecting the points, and I think publications, you will be eligible for FICOG. So I wish that more and more people apply for fellowship. We have a conference coming up in Bangalore on 22nd and 23rd of August, Fertility and Beyond. 22nd, we are conducting convocation. And there will be 2 convocations, one in Bangalore and one at Surat. So those who are able to come to Bangalore, many who missed Delhi are willing to come to Bangalore, and then you can also come to Surat. So ICOG is a platform, a purely academic platform, where you get an opportunity to learn. And once you become a FICOG, again you can proceed further. You can become a governing council member, and you can be an academician, okay, can get involved in publications. So we are very happy to see that more and more people are joining, and we need, somebody is telling that we need publication. I think we have already released 2 ICOG campuses, which are again there, soft copies on the website. The first was on high BMI, and the second, which we released in was on placentology. We had a master class also. So we have this ICOG campus books also, soft copy. So you can go through that, you can download that, and it will be available there. And every UA conference will be releasing one more ICOG publication, and we will be still having 4 5. I can see Dr. Pranjal Sharma, a very bright member from Amravati Society, which is my hometown. So nice to see you, Pranjal, here. And
Hello, madam.
I
I'm
thank
honored
Dr.
to share with you.
Yeah.
Thank
Thank
you.
Dr. Vidya Thobi, the Vice President, and Dr. Anju Soni for joining, as well as all the faculty members and our governing council members. Thank you. And Pratibha for doing the coordination, and also the all the coordinators today.
Thank you so much, madam, for this opportunity to be the co-convener of this program. And I've learned a lot, and it's really an honor for me to be associated with ICOG. Thank you so much.
From my end, I thank Sadhna madam, Sheila Mane madam, and Pratik Tambe sir for the opportunity to be a speaker as well as to coordinate the sessions. So Sadhna madam, thank you.
Lakshmi, thank you for all
Moshami is
your
another very, very active
हाँ,
person.
मैडम से कहिए
Well done, Dr.
डॉक्टर
Mochri, in spite of
हेलो
the
मैम, आप
technological
अनम्यूट
challenges.
करके आइए, अभी है, मैंने आपको देखा. हेलो. Oh,
Thank you, Sadhna madam. Thank you, Sheila Mane madam. Thank you, dear Pratik. Actually, because of you, we are always eager to learn so many things. Thank you so much. Thank you, Pratibha madam.
Thank you. Thank you.
So we are all coming
We
to
will be
Amravati.
discussing the answers
Pranjal,
also here.
shortly. We are coming to Amravati.
Yes, madam, you are welcome here, madam. Amravati is eager to welcome you all.
Dr. Sudha Salan is asking, not able to get question link.
It has been posted at least half a dozen times in the group.
Dr. I can tell her.
Just
Please
scan
post
this.
it
Dr.
again.
Sudha, देखिए वहाँ पे chat box. You can just see the link in the chat box.
You can just scan this also. It'll
Yes.
come. This QR code can be scanned.
Very easily opened from the chat box.
प्रतिभा, सुधा मैडम का नंबर हो तो देखो, भेज सकते क्या, बोलो उनको. मैडम इज वेरी सीनियर फ्रॉम दिल्ली. नॉट सीन बोल रही है, चैट बॉक्स में ढूंढने को बोलिए उनको.
We welcome Dr. Sudha Salan, very senior teacher.
Yeah, that's what. She is not able to click the link.
Click the link. मैडम उनका नंबर है आपके पास, साधना मैडम?
किसका?
मैम
डॉक्टर
मेरे
सुधा.
पास है मैम.
हाँ, तो एक बार कॉल करके बोलो. On WhatsApp you can
Shreya, just
WhatsApp
share
you
the
can
link on Dr. Sadhana's WhatsApp.
Yeah,
She will
WhatsApp.
send it to her.
Yeah.
Yeah, Dr. SN Tripathi madam is also trying to log in.
She is there. I am seeing her name right from. She is
No,
still
she was
there.
like she
She's
was in
not
another
able to,
meeting.
like,
You have to
Now she's
score
trying to log in.
50% when you attend all 3 days. Then you are eligible to get the certificate. Otherwise, you get the attendance certificate. Hundred people have already submitted, so we can see the numbers going down. They want the answers.
Will be displayed after some time.
The answers will be discussed after 2 minutes by the convener.
Yeah.
Once the time is up.
Yes.
Hello, ma'am.
Dr. Pratibha ma'am, I hope you are ready with the answer, though.
Quick, how many minutes remaining now? 1 minute, 22 seconds. Result after attending 3 days, at the end after a week.
So, ma'am, we'll get the certificate on mail.
Yes. Yes. Next month, it will be on a mental health certification course. Master class will be on adenomyosis. Okay. So, and we have an international faculty for adenomyosis. Mental health is with RCOG.
Now it's over. So, can I read out the answers?
Yes, please go ahead, ma'am.
Yeah.
We're all
So
waiting
these
for
were
you.
the questions. First question was, which physiological change in pregnancy may mask early tachycardia and sepsis? And the answer was B, increased baseline heart rate. Second question was, which hematological physiological change in pregnancy may mask diagnosis of infection difficult? This is answer is A, physiological leukocytosis. Third question was, first line option for lower urinary tract infection is nitrofurantoin. Answer is C. Fourth question, a pregnant woman is in her first trimester is diagnosed with uncomplicated Plasmodium falciparum malaria. Which is the preferred treatment? Answer is B, quinolone and clindamycin. Fifth question, which of the following complications is most characteristics of malaria and pregnancy due to placental sequestration? Answer is B, IUGR. Sixth question, a preemie gravida at 36 weeks of pregnancy comes with dengue fever in the febrile phase. The answer is C. Patient should be admitted and kept under observation. Seventh question, the danger signals of dengue include all except, answer is A, fever more than 101 degree Fahrenheit. Eighth question, compensated shock in DSS is denoted by, answer is A, pulse pressure less than 20 millimeters of mercury. Ninth question is, anti-tubercular drug contraindicated in pregnancy is streptomycin. Answer is C. 10th question is, active pulmonary TB diagnosed at 8 weeks pregnancy. Correct option is A, immediate treatment with rifampicin, isoniazid, pyrazinamide, ethambutol daily for 2 months, followed by daily RHE for next 4 months. 11th question is, management of neonate born to a sputum positive drug sensitive mother. Answer is A, rule out neonatal tuberculosis, continue breastfeeding with face mask, BCG and TPT for 6 months, INH. Now, 12th question is, the hepatitis virus most commonly associated with severe maternal disease in pregnancy is, answer is D, hepatitis E. The risk of vertical transmission of hepatitis B is highest when the mother is, answer is B, that is hepatitis B surface antigen positive and hepatitis B surface antigen positive, BE positive. Which antiviral drug is preferred in pregnancy for high HBV viral load? That is tenofovir, that is answer is B. Which intervention has the greatest impact on the prevention of parent to child transmission of HIV? Answer is C, maternal antiretroviral therapy. 16th question is, pregnant women with influenza are at increased risk of which complication? Answer is B, severe pneumonia and respiratory complications. 16th is which antiviral drug is recommended for treatment of influenza in pregnancy? Osteomovirus, that is B. Answer is B. Now, COVID-19 vaccination in pregnancy is recommended for pregnant women. Answer is B. A 29-year-old Gravida 2 Para 1 at 30 weeks gestation presents with high-grade fever for 4 days, severe myalgia, headache, and platelet count is 48,000 per millimeter of mercury per cubic millimeter, and hematocrit is rising, and ultrasound shows mild ascites. Fetal heart rate is normal. Answer is B. Aggressive IV fluid therapy guided by hematocrit and clinical status. 20th question is, a woman at 39 weeks in labor develops fever of 38.9 degrees centigrade and maternal tachycardia, fetal tachycardia, and uterine tenderness. Which is the most appropriate management? Answer is B. Start broad spectrum IV antibiotics and expedite delivery. These were the questions. Thank you so much.
There are some queries regarding answers. 2022 guidelines, falciparum malaria treatment is, according to her, is the first A answer. So tomorrow, I think better we.
Yes, yes, ma'am. Even I agree, because in my slide also I've written that.
Okay. So I think then we will have to consider that as a answer if somebody has answered. Okay, Dr. Sadhna?
Maushmi,
We'll accept both.
is the, yes.
Yeah, we will accept. Yeah.
Maushmi has
Accept
given
both
this
is okay,
answer.
sir.
So we will say.
Anyway, we are
Okay.
giving certificates to everybody.
But now people have already self-correction is been done. Pratik, I appreciate their enthusiasm. Big clap for them, you know.
I'm happy till 8 o'clock in the night. They're still there.
And there are
They're
some
correcting us.
Ipsita Praharaj has 20 correct. Congratulations.
Madam, I think there are a lot of questions on nitrofurantine, ma'am.
Yeah.
I think that was also in the chat box.
Yeah. Anything you want to say?
No, that had to be cleared, I think, ma'am. The clarity of first trimester.
Yeah, third trimester we don't give, first trimester. And
I
one
think
more
Dr.
thing is,
Sadhna Gupta has also responded regarding that it's bacteriostatic, it's not bactericidal. That's
yeah,
why it's not
exactly.
the
Yes.
first choice.
It is not. And for a recurrent, I think we have to give an extended course.
Yes.
Yeah.
Madam, the panel questions which was framed was excellent, ma'am. Dr. Aradhana Singh and Dr. Sanchita.
Thank you.
Yeah,
Thank you
Excellent.
so
I
much.
think the time gap what we got
Absolutely,
was
absolutely.
Actually, it was
very
less
practical
time.
questions.
very practical oriented questions.
4 घंटा बिठा दिया.
Thank you, Sheila ma'am.
Thank you so much.
Hi,
मैम
Sanchita.
आप पहले शुरू करते ना, 4 घंटा हम
संचिता,
पैनल ही करा देते.
पहले ही करा देते. नहीं, हम और एक बार करेंगे, डोंट वरी, हम करेंगे.
Yes.
हम लोग उसको आराधना ये I think you are doing with us ना, this is third
Yes.
time I think one is
Yes, ma'am.
Aradhana.
I've done it.
So we will like subdivide in the different, क्योंकि वो rashes is their area where is a
Yes.
lot of confusion and we tend to forget कि कौन सा rash कहाँ से होता है, तो हम इसको थोड़ा part में करके और
Part
थोड़ा
में कर
like we will make it intricate and in depth.
Yes.
So
चलो,
full
thank
panel
you.
is very
Thank you,
difficult.
ma'am.
Full
बहुत
panel is
अच्छा
very
हुआ.
So thank
Very good.
you, Sheila madam. Thank you,
हम तो
Dr.
दो
Pratik,
प्रोग्राम में, इधर
Dr.
पीजी
Sadhna
प्रोग्राम
Gupta
चल रहा है.
madam. Thank you so much. Thank you so much.
Sadhna ma'am,
we
thank
have,
you so much for involving us in the panel. Thank you, ma'am.
if
And
there
Thank
are
you,
any
everybody.
postgraduates,
join
log
in
into
the same
Gurukul
number.
website.
Thank you so much, in sir. a bigger number,
Yes,
in a larger
Thank
number.
you, Dr. Pratik, Sheila ma'am, Sadhana ma'am.
I think
Love,
Pratik
lovely,
sir's lucky
lovely.
charm is the chair behind.
Yeah. That is.
Dr. Pratik, I think you are sitting in the cockpit or what?
ये पुराना वाला मेरा बैकग्राउंड है.
That is, I think,
That's the
बहुत
lucky
पुराना
charm,
प्री
ma'am.
कोविड वाला बैकग्राउंड है.
the cars or what?
That gives a, that appearance of, controlling the timings and everything.
I'm the least controlling person you will find anywhere.
The time
Time
setting of the webinar.
अब हमको उसको बोलना पड़ेगा. Oh, bro.
Like the scientific
I think the
fictitious
recording has
movies,
stopped.
na? It's like
Please
that.
stop the recording.